Okay, calling the Special Committee on COVID to order. First on the agenda, we'll hear from, is it Hi Pam? Good morning.
Good morning, Chair Dela Cruz. My name is Victoria Fan, and with me are my colleagues from the university, Professor Monique Shiba and Thomas Blamey from Maui College. I want to just start off noting that we're representing ourselves and we're not representing the university with the views in this presentation. So we really greatly appreciate this opportunity to present our HIPAM COVID forecast from August 28th. I just want to give a brief background about HIPAM, which stands for the Hawaii Pandemic Applied Modeling Work Group. We are a voluntary partnership of Hawaii-based epidemiologists, data scientists, and health professionals. And we continue to calibrate our model to provide what we think is the best forecast for our state based on most recent data, best available evidence. And of course, the biggest challenge with this is the ever-evolving science. With that creates tremendous uncertainty and changes and tremendous confusion as well. And so we approached our work with forecasting with humility as scientists. I also want to make a note that forecasting and modeling are essential tools for planning, for mitigation and preparedness, and for the economy and health. Since April 2020 last year, HIPAM has closely monitored COVID and the data. We've examined the influence of these different policy interventions on COVID. We've maintained since July of 2020 a 2-week COVID forecast, which calibrates different models. And in the past 7 weeks or so, we've actively communicated to the public about the forecast. And also more last year, actually, upon request, we provided scenario and decision support of different interventions, the so-called what-if scenarios. I also want to emphasize that HIPAM, in our work to provide the best forecast, we do not advocate as a group for or against any particular intervention. We seek to just sort of provide the information that would be needed for the decision makers and policymakers for the critical decisions for our state. Just some high-level key messages for our presentation before we go into greater detail with Monique, Professor Shiba, and Professor Blamey. In Honolulu City and County, test positivity has been increasing. That is, as you know, a leading indicator for a surge, but test encounters were, for a period, decreasing, indicating underreporting of cases. I think this week now, encounters are back up. That's a good sign. COVID cases in Honolulu City and County continues to trend upwards, I'm sorry to say, and neighbor island counties also appear to trend upwards, though less steeply. And the model suggests that the need for total hospitalizations will likely surpass 500 in Honolulu by September 13th. I think today there's 38 hospitalizations, so we're getting quite close to the 500 for the entire state. I will note that some past modeling work that we did indicated that the tier system and also the Safe Travels program were likely supportive in controlling some of the spread. As we all recall, that negative incentive of going from one tier to the next tier to a worse tier may have influenced people to act more safely. And also, Safe Travels, as we all know, gives more protection, but especially since there's evidence now that vaccinated people can spread asymptomatically. And as we all know, timeliness, transparency, and public trust are essential, and really there's no silver bullet, unfortunately, for COVID. So with that, I will pass it on to Professor Shiba.
Great, thank you. Do we have the slides somewhere or that are available?
I'm sorry, I've been going through the slides here. Let me share it now.
Thank you. All right, so I will discuss a little bit the model. So it's been done in emergency over the past 2 months. With the arrival of the Delta variant, it changed a lot of the forecasting and the game of the spread of the pandemic. We have to be careful not to use the model as a prediction, as an accurate prediction tool, but rather as an informative tool for the extent of the pandemic and the scale of the healthcare problems. So mostly looking at trends. So if we can go to the next slide, Victoria, please. The one before, well, it's okay. Just to mention where the modeling is coming from, we are using two different types of model, a region-based model that is called COVASIM, and that we then adapted to Hawaii and the specificity here. It has been developed initially by the Institute for Disease Modeling, and we've been working with them to learn how to use the model and how to run it. We have a virtual population for the island. Then we have another model, a compartmental model that we built in-house here and that we calibrated to Hawaii. The reason we work with two models, they are structurally very different, and we wanted to validate the fact that what we were seeing, the trends, were not due to assumption in the model, but were actually due to the pandemic and its evolution. So we use both models in order to advance with our forecast. So the models are based on publicly available data, which sort of limit also the type of forecasting that we can produce. Then each county has followed a different evolution. This is something that we have studied. It is in a paper that is on the archive and that is submitted right now for peer review. And therefore every county require a different look and a different lens to look at the evolution. Kauai so far has been out of the forecasting, and the reason is that the number were very low, and you cannot calibrate a model on very small numbers, but they are sort of growing, and we're looking at developing the model for Kauai as well. So if we can go into Honolulu, the slides that you see right now showed indeed that was about a week ago when we saw a discrepancy between positivity going up and the number of testing going down. This is usually a warning that there is a surge coming down the line, and it is a little bit what we saw with the number at the end of last week in Honolulu. There is a question was also regarding when the numbers were released. So if we can go to the next slide. So here, this was to August 28th of last week. We are working right now to readjust the value over the weekend, and we'll see, but the trend seems to be keep going up. So one thing that you can see, the little red, orange dots, those are the actually daily numbers that are reported. And the difficulty that you can see is that from one day to the other, there can be as much as up to 40% difference in the daily cases. We also know that sometimes some daily cases are released at a different time than when the tests were collected. So all of these include some uncertainty into the actual flux of the pandemic and the evolution. So what is clear here is that it's an overall trend. It does not show signs of slowing down or plateauing completely at that stage. If we can go to the next slide. All right, so now we have a little, the forecasting. The red upper line shows sort of the worst condition. We're assuming that vaccination goes down and that transmission rate goes up. It can be because of less compliance or people doing some gathering. And then the blue one is more conservative, assuming vaccination is going up and transmission is going down, because people they might decide to be more careful. It is impossible. People are very, very complex. It is impossible to predict the trend and what type of behavior they're going to do in the next 2 weeks or a month. But the green one is sort of the averaging and assuming no change in vaccination and transmission. So you can see that it goes slightly going up. So if we can go to the next slide. This is more long-term, so this is a very dangerous prediction, of course, and we predicted a while ago a large number of 2,700 for Honolulu, and it was what would have happened. That is still in the realm of the possibility if nothing is done. That was really a warning and not like a number that we were projecting in October. But the cone, you can see the cone of uncertainty. It is very large. And however, it brings one of the good news that can be positive or negative is that a very slight perturbation, so some slight changes in mitigation can have a very large impact because the nature of the spread of the pandemic is exponential. That means, again, a very slight increase in vaccination that can be as small as 5% can really impact the curve and smoosh it down. And the same thing with mitigation measures. If we can go to the next slide. Thank you. So hospitalization. So this is right now, I think, the hot topic and one of the issues. So it's very difficult to predict hospitalization. The reason is that hospitalization count are going to depend on who is getting infected. And that means the age, the health of the people that are getting the virus, and that type of information is not publicly available. So we are forecasting hospitalization as we can with what we have, and we are learning about every week if there is a change, if we can suspect or speculate a change in the demographic of the people that are getting infected. But you can see the trend is up. What you really have to keep in mind is that hospitalization typically lag 10 days behind daily cases, and the fact that daily cases have been going up is a sign that hospitalization is very likely to follow. So here what you can see, this is for Honolulu, you can see that in August there was a clear exponential trend. Again, the orange data are from the HIEMA website, the publicly available data aggregated for Honolulu. You can see there is a clear exponential trend about the hospitalization, and I know that we're sort of reaching the brink of the 500 cases for the state today, and we are concerned that the hospitalization might not plateau unless there is something hidden in the demographic of people that are getting infected in the current daily numbers. Here, another thing to look at and to keep in mind, and it's in the orange bubble, in the yellow bubble, sorry, is that we are forecasting the need for hospitalization. We're not forecasting the hospital capacity. There is no carrying capacity in this model. We are just saying what we forecast the need for hospital bed will be. So if we can go to the next slide. So we're going to move to the Hawaii County. So Hawaii and Maui they've been in the footstep of Honolulu, and more so Maui now. That was lagging behind in numbers, and the reason for that is that we also kept an eye on the Delta fraction of cases per county, and right now it's everywhere. It's about 100% of the cases are the Delta variant, but Maui, the Delta variant, was less aggressive at the beginning, so they were lagging 2 weeks behind the other county, which is why they're catching up right now. They didn't reach 80% of the Delta variant on Maui, but 2 weeks later than in Hawaii and in Honolulu, which is, again, a little bit what we see, but we'll see the Maui number after. So what we have right now in the Hawaii County is that the positivity is stable. However, it's the highest as of yesterday from all the counties. So that means there is spread, there is community spread, and there is really the potential to keep trending up, which is sort of what we see. Then if we can go down, yeah. Okay, so this has been the latest trend. We see a little bit of a plateauing. This was the ban on gathering, the mitigation that was made sort of on the gathering, and we see it's more so impacting the outer islands because the numbers are smaller. If we can go to the hospitalization. Okay, so this is the forecast. So again, trending up, and you can see sort of the worst case scenario versus the lesser case scenario, the less severe, the blue one, which would show a nice stabilization. But if we can go toward the hospitalization, oh, okay, so that's the cone of uncertainty, but I think the hospitalization is actually the one that is the most relevant. So you can see that the last 2 weeks of August they have seen a quite severe asymptotic uptrend. Right now, it seems to be on the curve of the less of the higher vaccination on the blue curve. As of yesterday, EMA was saying like 66 hospitalization. So we seem to be in between the blue and the green curve. However, the numbers they are not looking at going down again unless the demographic of the population that has been impacted is something that we don't know. If we can go to the next slide, and then Tom, I'll let you talk about the situation on Maui.
Aloha, Senators, and thank you for inviting us to talk today.
Aloha.
Victoria, if you can flip the slide, I'll try to talk a little bit about Maui. It's going to have a similar experience, right? We're a little bit behind, but we're experiencing the same effects of Honolulu and Big Island. And again, these metrics are going to be the same for here. So if you flip, okay. So right here, as Monique was discussing, we have magnitude, we have direction. Magnitude's a really hard thing to get a handle on. Everybody wants one number, but one number doesn't exist for the future. That number is going to be wrong. The question is how wrong. But what we can clearly see is the red arrow, and the red arrow should tell us something, right? Red flashing lights. When it's steep curve like that, what we'd like to see is that red arrow going down. And until then, we should be a bit hyper vigilant. If you can flip the page, thank you. Again, the forecast, the same model, same kind of experience happening on Maui. And as Monique says, we're a little bit behind, so the volatility, the numbers a little smaller. With the way this thing works, right, with super spreading events, any day of the week, we could see a real rise, so we need to be concerned. Victoria, if you could flip again. Again, even broader cone of uncertainty view of it. Victoria, if you flip again. And now we're looking at hospitalizations, the real concern now, right? So I'm sure everyone's paid attention to Hawaii today. I think they have 25 ICU bed folks and 24 beds. So there where nobody wants to go. And I'm sure praying that Maui doesn't go there. And again, here's hospitalizations lag behind infections. So you can see that the steepness of the curve here is still there, where infections maybe are dampening, we hope. Victoria, if you could flip. A couple caveats. This word uncertainty, right? We don't actually know the future. We're just trying to help with the trends of today. And one thing that Monique discussed is this exponential growth. So most of us deal with our daily lives in sort of a linear fashion. And so we're not used to an exponential experience. It really sneaks up on us very fast. And it's sort of tragic, if you will, right? Standing in the middle of the wave when it's about to crash. And this data is lagged, right? So what we're seeing is got some kind of lag to it. Future model considerations are risk, and so as we've been experiencing last year, there's so many factors that come into play that it's really hard to predict exactly what this number is going to be. But most folks are doing great at getting vaccinated, wearing the mask, bringing their bubbles tightening in, thinking about this. A lot of these kind of models are seasonal. What we're seeing is more of a holiday event, right? So instead of a seasonal event in Hawaii, we're seeing Monday as a really big challenge. So hopefully this weekend, we're crossing our fingers that we don't see bad events from that. Okay, key emerging issues. Not only are we seeing COVID, but the potential for flu at the same time. I'm not sure if everybody's got their flu shot yet, but if both of those happen at the same time, it could be a horrible event. Right now, last year at this time, we had COVID, but we did not have tourism. And so the hospital beds didn't have that impact. And now we're seeing, them being somewhat overrun. because there's a lot of competing resources. So flu would be another competing resource there. We are seeing waning in the vaccines. Israel data, UK data, predictive experiences from people ahead of us that maybe we don't have the same protection. It's still very strong for death and hospitalization, which are the most important, but we can transmit, right? For vaccinated, some percentage of us are still going to be able to get COVID and transmit and be a burden to that experience. And I know some of us are watching the news and watching Dr. Fauci and seeing other variants, and we're just crossing our fingers that there's not a worse variant than Delta coming around the corner. Victoria, if you could flip. And I believe that's it. Malos.
Thank you. Members, any questions?
Dr. Fan, on the beginning of each county, the chart that you shows that says test encounters are decreasing, indicating underreporting of cases. I don't see a number on the left side of the graph.
I apologize. We can get that to you. There was an issue with this.
Yeah, it's
x-axis.
Yeah, it's the and it's the graph that shows at the beginning for each county, but yeah. See, there's no number on the left side, so I'm not sure how many we're looking at.
This is, I can just answer that. The numbers are between 0 and 1. We had to normalize so that we can see the curve together. The number to the left, they don't mean anything. It's just, again, it's a normalized curve without unit, so that we can see the trend of both the test encounter and positivity. If we would put them without normalization, then you wouldn't see the orange line, for instance.
I see. Thank you for that explanation.
Yeah.
Are you saying that the increasing number that we're seeing, could it be because not enough people were testing previously?
No, what we're saying is that if you have an increase in positivity, if you see an increase in positivity and a decrease in testing, and then you sort of fix the issue, you're going to see growing numbers. That means it's going to show a surge into the daily cases because you might not have detected everybody before. It shows that testing is absolutely critical. If you don't do massive testing, you might be missing the actual picture of the situation.
So this shows everyone basically who has been tested, including those who have already been vaccinated, not necessarily just those ending up in the hospital. Is that correct?
This comes from the YIMA website where they just gathered together. That's publicly available data that says that's the number of testing. The blue line is the number of tests that were administered that day in Honolulu, and the orange line says how many of them came back positive. It's just a percentage.
Thank you.
Senator Keoho Kalole.
Thank you, and thank you to all of you for this presentation. It's really helpful. Can whoever's controlling the presentation go back to the cone of uncertainty for, I guess we can do Oahu. Okay, so regardless of which of these models you folks, which of these assumptions actually takes place, it looks like from this chart, at a minimum, this is Oahu, that you don't see the surge starting to subside until November, in the best case.
All right, so we have to be cautious here. This depends. If you decide for lockdown starting tomorrow, we're going to see the daily case going down 2 weeks down the road, which will be mid-September. But with more conservative measures, it's going to take a little bit of time to start to stabilize. This is This is assuming that mitigation will bring the transmission down by about 6%. I cannot give you quantitative about what type of mitigation is going to do that. So you might in the end decide for more severe mitigation that will bring transmission down by a larger number than 5.8%, in which case we would bring the top of the the top of the curve a little closer to us.
So does your assumption take into account the vaccine mandate? Because that takes effect in the middle of September.
Yeah, this is hard to, yeah, okay, no, those simulations are, they came from August 28th, where the vaccine mandate was still up in the air, I believe. So we are going to put that into the model, but it's hard to know how much it's going to translate. I don't know how many unvaccinated people were actually going to the restaurant. So that means the quantifying exactly how much the transmission will go down by the vaccine mandate is extremely difficult because we don't have the data for that.
Yeah, thank you.
Mm-hmm.
Any other questions? So I guess I just have a general question. How often do you make this available and who do you provide it to?
Maybe I'll take a stab at this question. Professor Shiba and her team of graduate students has been doing this voluntarily in their free time, I'm sorry to say. They had a National Science Foundation grant that ended earlier this year, and so they've been really just doing this out of the concern, obviously, for the state. At this current, for the past 7 weeks since July 15th, we've been producing it each week and basically spamming it to every single person we know. We have been including it to the Department of Health as well, and who are on our HIPAM list.
Okay, so when you send it to the Department of Health, do you also send it, is there to the public, is there a media release that you send out, or is it just going to Department of Health?
In the past, I would say, last year we would send it originally to the Department of Health. In the past 7 weeks, we've been doing it simultaneously to both the Department of Health and the media.
Okay, thank you. Any other questions?
No.
Thank you. Thank you very much.
Thank you.
Okay, next on our agenda is the Attorney General to discuss our statewide strategy of restrictions to avoid large gatherings and large events during the weekend. Good morning.
I think I'm unmuted. Am I muted?
We can
great.
hear you. We can hear you.
Okay, great. Thank you, senators. Appreciate this opportunity to talk about what is an issue on the minds of a lot of us in our conversations with our fellow state counterparts, as well as the county police department and our all those who are committed to ensuring that we are moving into this weekend in particular with all enforcement measures available to us and ready to go. So in short, I'll just give an overview. Our department has been doing a number of different things. We continue to focus most of our efforts on the Safe Travels program, and there continues to be press in a good way because it helps us with deterrence about the things that our department has been doing. So we continue to focus on the fraud that we know is inherent in a system like Safe Travels, where we have the volume of folks coming through, using 2 of the exceptions to our Safe Travels program quarantine requirement. We have the vaccine exception, and we also have the negative pre-travel test exception. So when we, either through our screening processes at the airport or reports from the community, and again, I encourage folks to report things that they see. Those provide us the kinds of tips that we need, and we will follow up on every single tip that we receive. We are investigating these cases, and we are prosecuting them. So I think we sent yesterday to the committee our latest statistics. We have, as of this past week, arrested 7 different individuals for attempting to get into the state using a fraudulent vaccination card. We have in total arrested more than 60 persons for travel self-quarantine violations. We talked a lot about that last year when we had mostly individuals quarantining. And then, of course, we had the negative pre-travel test exception, and now we have the vaccine exception. So we've moved with all of those different avenues of coming into the state with our enforcement response from our department. And again, it complements what's happening what's happening on the neighbor islands with their respective police departments, because they all have similar programs set up to ensure that folks are complying with travel self-quarantine and otherwise complying with the law as set forth in all of these different emergency orders. So we have done, our department has assisted the county enforcement efforts by conducting more than 4,000 compliance checks. We've talked before about how we do them. We identify both persons who are staying in hotels. We have a great relationship with hotels who have quarantined persons staying with them. They report to us items of concern, but they also continue to use the one key systems and all of these other reporting mechanisms that have now become rather routine aspects of our travel quarantine programs. In addition, we go out into the community and we meet with persons who are in our residential areas, basically returning residents who have traveled and who are in travel quarantine, and we check on them. Like we've said before, our feedback from those who've been contacted by our investigators is good. They're happy that we're out there checking on them. They are happy that they are doing their duty to take quarantine, and that continues to be the case. That said, as I mentioned, since we've been at this quarantine enforcement, we've arrested more than 60 people. So we do address, when we see noncompliance, with the appropriate investigative and prosecution resources in our department. One of the big changes that we have seen is related to what happened with Act 185 last legislative session. We talked a lot about how challenging it was for law enforcement to have only the full misdemeanor available to them when they were seeking to arrest people who were violating these various orders. And of course, we saw what happened to the court system as a result of having these full misdemeanors being processed through the court system. So that changed with the legislature's passage of Act 185. Now we can impose infractions, which are not necessarily criminal violations. Well, they're not. If they're infractions, they don't go through the criminal violation process, and they can be attached to lesser penalties, right? So how the legislature did it is they put it within our traffic code. So now they're treated like your traffic offenses, right? If you have, and Hawaii County has already implemented something. So in Hawaii County's orders, I think effective August 27th, if you violate one of the mayor's COVID emergency regulations, you can be guilty of an infraction in the amount of $250. So that means you have the option, as you would a parking infraction, to pay it and be done. It doesn't ever see the court system in terms of having a prosecutor get involved or having to go and litigate matters. If you decide to contest it, the same way you have that option with the traffic infraction, then a prosecutor would get involved, and then you would go through that whole legal system. So that is a good development that has given the flexibility that we heard former Chief Ballard talking about and other chiefs talking about to the police when they're actually there engaged in some kind of law enforcement action. So that's been very positive. We thank the legislature for hearing those concerns, for taking the appropriate action and giving that level of flexibility to our law enforcement officers. That's made a difference. We have heard and can expect to see more enforcement this weekend. I think Honolulu PD has been very public about the fact that it will be out and about enforcing. I know the other county police departments have said as much, that they are going to be looking at the gatherings, they're going to be looking at the violations that they come across, and they're going to be taking action. So everybody in the community should continue to do what is responsible at this point in time, which is to follow the rules, to ensure that you're doing what you can to keep your family and the community safe. Many people in our community have a higher level of vaccination than when we were talking about these issues last year. That's helped, and yet we still have to act as if people are infected. So we need to continue to wear the masks as prescribed in the rules. We need to continue to safe distance. We should not gather in groups that are larger than 25, and when you're outdoors, or larger than 10 when you're indoors, and should really take care this weekend when we're making decisions about how to enjoy the three-day weekend. So that's a basic overview as to where we are, the different things that we are seeing. I think I've covered most of the issues. The fact that we have fewer people traveling generally helps, right? We saw that message go out from the governor. As you look at the daily travel numbers, it's about 10,000 fewer than it was a week ago or 2 weeks ago. All of that helps add less stress to the system, which also helps law enforcement be able to respond more effectively to. I'll leave it at that, and any questions that you have, happy to answer them.
Senator Kim.
Good morning, Attorney General. Thank you very much. How many infractions have we given out?
That is a good question. As I said, Hawaii County has gone ahead and done what needs to be done to ensure that infractions are part of the county regulations. So Act 185 passed, then there needed to be additional steps taken by the counties to set forth those penalties. And that's in process in all the counties right now. Hawaii County is the first to have something that's actually in effect. So I don't know how many infractions Hawaii County has issued under its new lesser penalties provisions. I'd have to defer to them for that.
Well, what's the estimate time before Oahu implements infractions?
I would defer to Oahu on that. I believe there's a press conference happening this afternoon that has the governor and the mayors, and even I think the police chiefs. So there may be an announcement later on this weekend, later on today, about that very issue, Senator. Okay,
well, I'm just concerned because, you know, the legislature went ahead and passed it, and here we are now in September. It was into law, when did it get? In July? The governor signed it sooner than that?
Well, I know what we did is in June or July, our office convened a meeting with all the prosecuting attorneys, with all of the police departments, and I believe certain of the county representatives, because we wanted to help, the judiciary, because obviously all those parts are important to work together. So we held that meeting in July, I believe, to make sure everybody understood the law, to make sure that the judiciary was at the table. And then, as I said, Hawaii County has gone ahead and implemented something, and hopefully the other counties will follow suit soon.
Well, I mean, I hope we're proactive in moving them along because, you know, a couple months, I mean, this is important that they know there's enforcement out there so we can deter people who are violating the law and that these infractions are given out. So, you know, if Hawaii County can enact it, I'm not sure why it's taken Honolulu County, which we have the largest amount of cases, so long. And, you know, if someone from your office is not prodding them along or somebody's not prodding them along and have an idea, okay, what's the timeline? When is it going to be doing enforcement? Because the biggest complaint I get from constituents and people out there is that our lack of enforcement, that they believe that we're not enforcing. So the next question I have is, how many investigators do you have, and how many are doing enforcement in your office? Because my understanding is the police is not really doing enforcement when it comes to quarantine breakers and you know, those sorts of things. So how many do you actually have?
Sure, and in terms of the precise numbers, Senator, I have to go back and check on that because, you know, things change with hiring and retirements and things. But I'll say I have between 40 and 50 investigators. They are tasked with doing a number of different statutorily mandated investigations, many of which have been in the newspaper and the press on completely different matters, on top of their regular duties, because they're not community police officers, right? They're not out there the way the community police officers are. But on top of their regular duties, they have then devoted their energies to, one, prosecutions of, or I should say first investigations of vaccine fraud, vaccine card fraud, negative test result fraud, and travel quarantine. So they're doing that on top of their regular duties, and that's something that we've been doing throughout the pandemic.
So how many, so the investigators are also doing the enforcement and the investigating? The 40 to 50?
They are,
so you don't,
when we,
go ahead.
I'm sorry, Senator.
No, so I'm trying to get an idea of exactly, do you have anybody dedicated any of these investigators or enforcers dedicated to quarantine, fraud, and COVID issues?
Yeah, most of them are. Unfortunately, because of the way the funding works and the way that they are tasked out for their statutorily required duties as well, these have been duties that they've been performing above and beyond performing their regular investigations and their regular tasks. But the entire unit is dedicated to this, and they're very committed to it. They've again built really strong relations with the hotel operators, and they follow up very thoroughly. As you can see with the vaccine fraud, I think some of the press went into the level of detail that they go into when they are investigating these cases. The latest person that was profiled said she got vaccinated in Delaware. They looked at the card, they checked with Delaware, they followed up with the National Guard, they did all that, right? So that's a part of what they're doing on top of other core mission functions.
Okay, well, that's a concern. You know, can you break out what other they're doing? Because COVID, you have COVID money, and COVID money should cover more investigators that are dedicated to COVID issues. So it would be helpful for the public and for us to know your office, how many people do we actually have dedicated? Because this goes back to like our, testing, and it goes back to how many tracers do we have. So at this point, just to give us 40 to 50, they're doing other things. You know, we need to get a better idea. How many people are actually there enforcing this, and they're dedicated to doing that? What's our number, and then what's the results?
Sure. I can certainly do that, and I will just make very clear that we're augmenting what the county police departments are doing on Oahu, right? Because we're again not the community police force, but we are taking any tip or anything that gets noted at the screening level at the airport, and we're following up on that. Plus, on top of that, trying to ensure that we have a compliance system that could also lead to additional evidence that people are violating. But I'd be happy to break down further how these resources are being dedicated in our department.
Thank you. I understand that, and I know that the Honolulu Police Department is not putting that kind of enforcement like the neighbor islands, which then falls to your department. And that's why I'm trying to get a more definitive answer from you, because if that's all we have, then we want to know whether or not it's adequate or not. Because the things we hear in the public about residents who test positive but they're vaccinated, they're told that if they feel better they can start going out again. And so, they're individuals, they're vaccinated but they're tested positive, they're carrying it, and I'm not sure, are they out because they feel better and there's no enforcement? And is that why we have more community spread among our residents? Those are issues I think we need to deal with. Yes, we want to look at this weekend and all of the big groups, but you know what? We've had the spread before Labor Day weekend, and what are we doing to enforce and deter people from doing what they're doing, and not just a Labor Day weekend? So.
No, I understand, Senator, and I just don't know the numbers for Honolulu PD. I just don't track that. I think they are engaged in this, but I can only speak to what my department is
doing. Right, and I want that information from your department especially. Thank you.
Sure, will do.
How involved is the sheriff's in helping with the investigations or some of the enforcement?
Yeah, so the sheriffs have a specific statutory requirement too for the kind of enforcement that they do, but we have on occasion stood up the state law enforcement coalition as necessary to address events, and I do know that we are in conversation with the sheriffs. I can't, as I sit here now, Senator, speak to exactly what they have done, but I can only speak to what my office has committed to this, but I do know that they are part of some of these conversations, especially when the state law enforcement coalition gets brought in for certain purposes.
Okay. In light of what we heard earlier, is there going to be some kind of trigger during the weekend if the numbers increase dramatically, let's say on Sunday, because of the first day? What kind of other enforcement is being anticipated or contemplated if there is a spike during we can see the beginnings of a spike during the long weekend?
Yeah, I think that's why the governor and the mayors are having a press conference on enforcement this afternoon. And I believe it's to discuss exactly that issue, Senator. So I know what we've been trying to lead up to, as Senator Kim said, following Act 185, trying to ensure that all the counties understood it and could have the conversations with the judiciary so that we'd be better positioned to enforce, again, not just this weekend, but moving forward as we see these numbers go up. Because I think, you'll hear from Dr. Char, but the social gatherings are a problem. They are a big problem when it comes to spread, and there's certain measures that can be enforced with respect to social establishments and different establishments where there is a higher likelihood of transmission that could be addressed with better enforcement. So I think that's on everybody's mind, and I would assume that's what's going to be discussed this afternoon. That's that question.
Okay. I think there's been a lot of discussion about hospitalizations and the possible lack of oxygen. I'm not sure if because we've asked before, what are the triggers that might cause additional restrictions to avoid over exceeding the number of beds or the amount of oxygen that is available? What kind of conversations are you guys having on that?
I think that is a very active conversation. I don't want to speak out of turn because it's HIEMA and DOH are handling that, but I'm privy to multiple meetings a week. My staff are privy to multiple meetings a week. I know that the governor and the mayors are discussing it multiple times per week. So I'll defer to Dr. Char and Hilton Raythiel on the specifics, but I do know just from my involvement in answer to your question is that we're talking about this multiple times a day.
Okay, so I think for the public though, tomorrow is the beginning of the Labor Day weekend, and the more advance notice we can give people, then people can plan accordingly. But it almost seems like we always wait to the bitter end, and then people have to cancel plans. That's where I think where it affects certain businesses a little more dramatically than if they had additional time. So I'm not sure. Hopefully you guys can change that.
Yeah, no, I understand, Senator, and that's why I think that the focus right now is on enforcement of existing regulations, which are tailored to address exactly that, but need to be enforced. Absolutely.
Okay, so can you just briefly go over the legality of the pre and post test requirements for travelers?
For travelers, sure, absolutely. So we've had the pre-travel testing in place since October of 2020, right? 2020, I believe. And it's basically legal because what we're doing is saying you can come to our state. We're not restricting you from coming to our state, but we want additional safety measures for what happens when you're in our state. So you can come to the state and you can quarantine. Originally it was 14 days, and then when public health guidance suggested 10 days was appropriate given the incubation period of the disease, we switched it to 10 days, all reasonably tailored based on scientific developments and public health information. And then what we did is we said, all right, you can have an exception to the quarantine if you do a negative pre-travel test. And there was, again, no constitutional issue there because it was really just focusing on what happens once people come to our state. And we built up a big system. It's a system that has been worked on, revised, and improved greatly from its initial inception, and now allows us to ensure that people can get a test within that 72-hour period to demonstrate at least a point in time that they did not have COVID and they are not bringing it into the state. And then the vaccine exception is its own separate issue. Now with post-arrival testing, that's, if you remember when we were having this conversation a year ago, it was a resource issue, this idea of requiring people or allowing people to test after they arrive, as opposed to pre-travel, put the onus on our state to ensure that testing capacity. So it was a resource policy issue at that time. Now I do want to distinguish, because I think it's important, coming into the state is different from what it means to go back to work, for example, right? And so that's what under undergirded a lot of the vaccination policies that we saw come out a couple weeks ago, right? This idea of keeping our workplaces safe is a little bit separate from this idea of people traveling to the state and ensuring that they're screened and that safety measures are in place. So that's where we have a different set of prerogatives that we want to make sure are taken into account, and that's why you see testing there too, and possibly different types of testing requirements, even related to employees who travel, right?
Okay, so I guess the Department of Health or the state has said they're no longer pre-testing because of CDC guidance, but CDC guidance defers to the state.
Sorry, Senator, who's no longer pre-testing?
So we no longer, what are our testing procedures now?
Yeah, you can only get into the state if you're willing to quarantine for 10 days, take a COVID test before arrival that's negative, and that's uploaded, that negative result has to be uploaded prior to arrival, or if you have a vaccine exception. Those are the three. Yeah, we continue to be challenged. I was just reviewing an opposition pleading to one of the many lawsuits that we've had. The governor and I were just sued by an individual who doesn't like the testing requirement and thinks the state should be enjoined because he doesn't like the fact he has to get tested. But we've survived those kinds of challenges before, and we'll just keep defending them because they are lawful.
Yeah, I guess some of the concerns that were brought up to our office from specific groups were the fact that the pre-testing on the vaccinated no longer, I guess there's no pre-testing on the vaccinated, even though they could be infectious.
I see, right. So in other words, you can quarantine, you take a negative, you get a negative test result, or you have the vaccine exception. But the concern is whether or not vaccinated persons should also take the negative test, or take the test.
Take the test, correct. Because they could, because it seems that the data shows that they could still be infectious.
Right, and Dr. Char can talk a little bit more about breakthrough cases, which are, I think, the types of cases you're talking about, where fully vaccinated people are nonetheless coming down with COVID. Of course, they're faring much better. They're not getting severely ill. They have sniffles, sore throats, things like that. They're weathering it very well. They're not ending up, for the most part, in our hospitals. But there is concern about breakthrough cases. So presently, when it comes to travel, and we've talked about this too, is we have to be very careful that we're not infringing on that constitutional right to travel. So we've done everything we can to address what happens when people come to our state. But in terms of needing to comply with the CDC guidance and make sure that we're not going any way far afield from what the feds are saying on this issue, that's where we run into some challenges with the pre-travel testing requirement for vaccinated persons, right? So the CDC says right now, if you're vaccinated, you can travel domestically and do not need to test unless you are symptomatic or you've been identified as exposed.
Well, I think,
so that's what this.
I think it says fully vaccinated travelers do not need to get a SARS-CoV-2 viral test before or after domestic travel unless testing is required by local, state, or territorial health authorities.
I don't think that's actually what it says. Are you quoting from the CDC website, Senator?
Yeah.
Because it basically says that you have to continue to comply with local regulations, but I don't think it actually says testing being required.
Okay.
But I defer. I can look it up right now.
Okay, if you guys can check on that, because that's the information. Yeah. That's the information that I'm getting. I just want to go back to triggers, because as we reach maximum capacity on oxygen and hospitalization beds, is this a potential trigger? Would this be a result of a trigger to say, okay, now we're going to have to test everyone because we're too? If not, we're hitting the point of exceeding oxygen and hospitalization beds.
Yeah, again, we continue to talk to Dr. Char and others about what is needed and how we can tailor our policies to ensure that we're addressing the needs. I think right now what the breakthrough cases are suggesting to us is that even if you are protected by having gotten a vaccine, you have to act like you're infected. So even if you are fully vaccinated, even if you've traveled domestically and you've come into the state with a vaccine exception, you should act like you're infected. It's just safe for the people you are then interacting with. It's safe for the community that you're a part of. You should continue to wear your mask. You should distance yourself. I think in some circumstances, dependent on where you work, before returning to work, you might need to get a post-travel test. So I think that's a very real concern, Senator. And I think every person who travels, even if the CDC says you don't have to get a test to determine whether or not you're infected or not, you should act like you're infected, because we have these concerns, and we as individuals have the ability to do even what we were doing before we had the vaccine, which is acting like we're infected. So I think that's an important point.
Okay, if you can just have your staff double check the CDC website. It's under the travel section of their website.
Yes, I have reviewed it, and I know it does say that you have to continue to comply with any and all local and state regulations, but it doesn't expressly say with respect to testing, as I recall. But yes, Senator, I will check, and I will get back to you as follow-up.
Okay, any other questions for the Attorney General? Senator Kidani, followed by Senator Keohokalole.
Thank you, Attorney General. I have a question related to who does the public contact if they see large gatherings? Is it the police or is it your office?
It is the police. It is the police, Senator. Those are still the community policing officers are in our local police departments. And so if you do see that kind of activity, you need to call the police.
Okay, well, in some cases, they say the police don't respond. I've heard that from several people, so just wanted you to know in your meetings if you could stress to the mayor or the police chief that if we are to take this seriously, the police do need to respond.
I will. I definitely will, Senator,
Thank you.
for sure.
Senator Keohokalole.
Thank you, and thank you, AG Connors, for being here. So to follow up on Senator De La Cruz's question about the triggers, we had the counties initiated last year, not the administration, a tiered framework that published specific triggers that the public could look to in anticipation of action, whether it was to open up or to further restrict based off of the disease activity. I've heard the Lieutenant Governor in the past week and the mayor both cite, and the forecasters that presented to us before from HIPAM cite this 500 bed threshold in terms of the statewide hospital capacity to take COVID hospitalizations. That multiple people have said 500 beds is basically this red line in terms of statewide hospital capacity. And there's been, and I'm going to ask the Department of Health Director after what happens when we exceed, if we exceed that threshold. But I'm wondering why we haven't, again, had this discussion that Senator De La Cruz alludes to. Haven't the published triggers strengthened the standings of the emergency orders as they relate to the type of constitutional challenges that you continually see from members of the public?
Yes, Senator, and we've been defending dozens of these, and we've won every one because we have done exactly that. We've carefully thought through how they relate to the public health guidance, and it's changing, it's evolving, right? So that's the tricky part. But so long as I can say, and Dr. Char and I talk about this a fair amount, that according to Department of Health or according to our public health experts, this is necessary to address this. I feel confident going into court and defending these regulations. I think.
But isn't it fair to say that broadly published triggers and justification of the emergency order actions that you said continually change based on the dynamic nature of the pandemic, don't the local factors that justify these broadly published triggers, wouldn't that help in defending or even dissuading members of the public from initiating these types of legal actions that to date all of which have failed, and maybe save us a bunch of time and heartache?
I wish that were the case, Senator, but one of the great things about America is that you get to sue on whatever basis you feel is appropriate. So we've been responding to them all, but yes, you're absolutely right, they do. And so long as we keep doing exactly what you said, I think we are are going to be continuing to have to devote resources to the legal defense of these things. But also, when we're in court, it gives us an opportunity to actually distill fact from fiction, right? So it actually gives us an opportunity in a court of law to bring in evidence, to have it discerned, to have folks like Dr. Char as experts opine on why we're doing things. And I think it greatly helps the dialogue and the discourse. It explains to the public in a public record why we're doing it.
Nobody's watching the court hearing.
I know, why isn't anyone
You
watching
guys.
in court?
Right? And so that's why I'm asking.
Yeah.
In the fall of last year, the Honolulu mayor, who was roundly criticized for putting in place the triggers, put in place the tier system we were asking for, and everyone started watching the weekly case count averages because people realized you were going to go from yellow to orange or back down if we went over this many cases a day. So what I'm saying is in this Delta surge, we understand and I recognize the situation is totally different. It came on extremely fast and now we're in a crisis situation. So why not have some published, easy to understand and recognize triggers like if we get to 500 COVID hospitalizations statewide, everybody get ready, something crazy, something very aggressive needs to happen. And wouldn't that help articulate to the broader public the dialogue that you folks are having in court where people aren't watching or in the governor's office with whatever members of the healthcare community and the counties are there, so people understand that there's a lot of work and effort being put into this.
Yeah, I can't disagree. I think.
Okay, I have another question. At
Okay.
what point does the overall number of breakthrough positives place the medical justification for the safe travel vaccine exemption on shaky ground? At what point does the overall number of breakthrough cases place the justifications that you folks are defending for keeping that vaccine exemption for travel in place?
That's a great question, and it is one I ask regularly because so long as the data is continuing to show what it is showing about the vectoring of disease from travel, then we have to tailor our response accordingly. Right now, it's showing a low percentage, right? What we are seeing is that folks who are traveling, largely residents, who are coming back and using the self-quarantine exception. So they're bypassing the testing, they're not using the vaccine exception, but they are quarantining at home. Those are the concern areas for spread. We're not seeing, and Dr. Char can correct me if I'm wrong, but we are continually having this conversation. Once we see it greater than 1%, or once we get at a percent that does provide exactly that trigger, Senator, I think we'll be on better ground. Right now, we're just not seeing it. We're not seeing it come from or being tied to travelers who are using the vaccine exception or who are using the negative test result exception. We're seeing it more from persons who are bypassing both of those measures that are in place to create points where we can identify disease or points where we can mitigate disease transmission. And that's a different issue, right? So if we want to talk about possibly testing the quarantine population, that raises its own host of concerns. But because that's the data that I've been seeing, that's where we're focusing our inquiry as to what an appropriately lawful and reasonable response would be.
Well, I would like to ask a follow-up question about that because KHON on Tuesday reported that there are 45,000 local residents who are under quarantine. And if you're saying that you guys have done 4,000 total checks, then that seems like a pretty big ratio before you even bring into play all of the tourists, which is like another 38,000 if my math is right. But I will yield to the committee and ask another question after somebody else gets a turn.
Yeah, and the only thing I agree with that statistic 45, that's statewide. Our compliance checks are just the 4,000 that our office has done. So it doesn't include what other counties have done or anything to that effect. But we are tracking the travel numbers and we will tailor policies accordingly. And when we start, and again, I ask that very same question regularly to our public health folks. And once we start seeing something that causes concern and gives us that basis, we will do it.
Okay, any other questions? Senator Favela.
Thank you. The question I have is similar to what been said by Senator De La Cruz and Jared. The problem that it is easy for us to go on these scales and say where is the hot zone and let us know that the west side is the hot zone, but exactly what Senator Jared was just saying. when was it gonna come to a point that we was gonna have something like how you guys have this for the public? Because see, when public don't see it, you only have it in the court. We're not gonna know when to take these certain precautions in the community, and I'm gonna tell you why. Because my community is on the top of the list. Okay, no matter how much I go on Facebook, no matter how much I go to the community, and do everything I can to let them know the situation we're in. They ain't gonna take nothing serious unless it comes from our leaders. And you guys all know, I don't agree with Mr. Mayor Codwell all the time, but he had something, like Senator De La Cruz and Senator Jerry was just saying, he had something that the community could gauge to be careful. You know how scary it is for me? I'm vaccinated. My daughter going to the largest school that every single day there's a case. She's vaccinated, but she still can bring them home. We also can get them. But there is no visual effect for let them know where we're at, because the tier system would help with the DOE, would help with the restaurants, would help with the traveling. By not having one tier system, everything. Viva Las Vegas. You know what, people go in Vegas because you know there's no telling them, hey, you know what, calm down. If we hit this point, we'll go back to red. So then some of the stuff gets scaled back. But there's nothing scaling any of us back because there's no threat. Nobody knows what red zone, blue zone, green zone, any zone. All they say is 96706 is the hot zone. Where are the resources? Where's the education? Where's the help coming out there and educating the public? Prison systems, again, rising again. Where is the task force going into the prison system? Where is something educating the safeguard of the public? There's nothing. So here we are again, you're saying, you know, it's in the courts and this and that. But until we have something like that, until the governor, one of the mayors step up, or somebody steps up to do something similar, like I said, regardless of the fact that how everybody would criticize Mayor Kurt Caldwell, and going forward, we had on scale to saying, if we reach this part, all our restaurants are going to shut down again. You know, and we're going to have to stay home and work from home. You know, at least had one visual scale every day to help the public. You got to have these things because all of us who's not in the know, they're not going to know if we go on top of a Department of Health website or your guys' website. They got to have it on the news. So when the news say, hey, look, we're reaching this point, we're going to shut Hawaii down again. People get a little bit more responsible in their actions and what they're doing. Stressful. But it's easy to point the finger on the public gatherings and stuff, which is cool, but have some parameters. You know what I mean? Can I just say, oh, you know, oh, West Side is the hot zone? Okay, right on, we hot. But they're still going Vegas. What does that matter? Gotta say, hey, you know what? Curve back your guys' activities, because if not, we're going to shut down Hawaii again. Jobs going to be in jeopardy. You're going to be on unemployment. Unemployment going to be coming up. Everything will get stressed out. At least have something for the public on the news, either daily, weekly, monthly, because we're at a point right now that I seen, of course, my district, and I was shocked to see that Wahiawa was up there too. But that's the only we're seeing. We're only seeing numbers of where is hot, but what is the solution into bringing these things down? Not by just criticizing the communities or criticizing the local people. Tell them, hey, we hit this point right here, we shut it Hawaii down. Period. And that would curb everybody's attitude in flying all over the place and going all over. Every day, I'm going to tell you guys, every day I wake up, I'm scared. I'm scared not only for my community, but for myself. I cough one certain way, I think I get the corona. You know what I mean? I mean, it's very scary. You know, very scary that we're promoting stuff in the community with community grassroots base. And then later on we hear things won't be canceled. So we got to call all the health departments, all the people who say, hey, our efforts to educate the public will be canceled, which is not, because we're doing a public service. But that's not the point. The community don't know that. So now we're going to be in Nanakuli Village, offering vaccine and the booster, right? People are going to be scared to come out because you guys have put in place, you cannot do certain things. So then what does that affect? Did anybody say, oh, having one vaccine station is okay, you can go get vaccinated? No, we don't see that, we don't hear that. All we're hearing is that we're gonna shut things down because there's too much local gatherings and everything. So those activities are gonna be hindered. There's no parameters, nothing. And there's a lot of people in the west side is promoting this, not just me, other senators and representatives, including Senator Jarrett, is the same thing. But we cannot go do this and only 3 guys gonna come because the rest of the public's scared because of what the mayor and the governor is putting out. We gotta let them know if we have a vaccination station, mask up, be safe, and go get the vaccine if you want it. It's available in the community, grassroots effect. That's how we should have spent the money. That's how we should have educated the public. That's what we should do, and that's something that we need to do. I know the Department of Health is coming up, and not all the answers is to you, but that's the frustration that I deal with every day. We got the HONU finally in our community for the homeless. We cannot even gather them around because of the pandemic and the scaring of the mandate. You know, so those are the things that we just gotta kind of look into in getting something for the public to see visually where we're at, and Hawaii was shut down, and some more restaurants and businesses going out of business because we're not being more self-conscious and try to be more safe out there. We just want to let loose and going forward. So sorry, I kind of rambled on, but thank you for your time.
Attorney General, I think the predictability of the different tiers did help reduce some level of stress and frustration.
Yes.
So hopefully you guys can reconsider bringing that back.
Yeah, no, I appreciate the challenges with the messaging, and of course the tiers are lawful. So as a policy decision, they have no challenge there. And I guess what I was referring to is when we're in the court, it's a place where we actually can address a lot of the fears, Senator, that you were talking about, because we can then say, hey, look, this is what we're seeing, and here's the evidence that supports why the things we're doing make sense.
But that's
yeah,
that's different. Yeah, that's different than the tiers and letting the people know. And as Senator Kehokalole alluded, people are more aware. They track the numbers because they know that those numbers would mean either a shutdown of certain things or less restrictions or whatever the case may be. They can follow it more. And I think it's important for us to put things like hospitalization beds and oxygen in a tier system so we can see, because my understanding, for instance, like Queens today, they only have, they only have 58 ICU beds, but they have 81 ICU patients. So that's kind of scary, you know. I mean, if that continues across the state, and here we're asking what people call us all the time: is there going to be a shutdown? Is there going to be a shutdown? We get these calls daily, if not hourly, and we're not sure, because if there was some tier system in place, we could at least answer and provide some kind of guidance. So, Senator Kim.
Okay. Just a follow-up question, Attorney General. Going back to the number of investigators and so forth, have you hired more investigators during this period using COVID money?
Let's see. I know that we have definitely utilized some of the COVID resources for this mission, but I don't know if we've specifically hired. I don't think we've hired COVID designated people for enforcement.
Because if there's ever a time to hire 80, 90 hires, this is it. Yeah. I mean, your office have had 80, 90 hires for years.
And that's a lot coming from her.
Yes. So, I mean, that's the whole purpose of 80, 90 hires. Temporary, we need them now. You know, let's get them on board. Let's augment your force so we can have some dedicated 80, 90 hires working on this. But if there's ever a time, this is it. So you have the funds, let's see it.
Senator Kim, you and I are part-time, so we can go 80, 90
okay, yeah, you can deputize me out.
Senator Kehokalole.
So I want to go back to the enforcement. That Alan Davis big super spreader party that they had that made the news, that was state property. So who did the enforcement on that?
So it doesn't matter if it's state or private property or anything. You call the police departments because they have jurisdiction to enforce everything. But as you do know from the reports, our DOCARE officers were out there And police, the Honolulu police were also out there. They provided support. The decisions that the law enforcement officers make happen in a split second when they're encountering a dangerous situation. And in that case, they saw this huge crowd, which nowadays is dangerous in and of itself because of the transmissibility of this disease. So their goal was to disperse, like to get those folks away from each other, make sure that distancing was in place, but not to the exclusion of following up. My understanding is DoCare is continuing to follow up. They're continuing to look at who organized it, how it got prepared. I know University of Hawaii is concerned. They're cooperating with the state. So just because at that moment in time they weren't standing there with people close, unmasked, handing out citations, doesn't mean they're not following up. They are following up, and they are going to try to get to the cause of how that even came to be.
So there are more than 4 individuals that were cited as, in the news report they said 4 individuals were cited, but you're saying since then further investigation has been conducted and other individuals who are identified at that event have been cited as well?
Actually, I'm not directly involved in the investigations happening through DoCare, but my understanding is that just because they didn't cite people there didn't mean they stopped investigating how it came to be and who was in charge. They are continuing to look into it. So I don't know if they've cited or charged anyone after that, but I know that the investigation is continuing. I know that they're working with the University of Hawaii. In the same way, when there's a function that has a large number of military service members, just because you disperse the crowd for safety reasons doesn't mean there's not a bunch of follow-up that could happen afterwards with either the military command or as you find out more information or talk to people or figure out, because you want to get to the promoters, right? You want to get to the people who thought it was a good idea to put on this event and to attract all these folks at least at one end of the spectrum, right?
Well, but doesn't the lead investigator depend on the jurisdiction? Does it? Because you just said, DoCare was the lead on that in coordination with the law enforcement officers. And then I understand, okay, so once law enforcement personnel show up at these large gatherings, they have to take account for their own safety. So you follow protocol. But then on the follow-up investigation, is DoCare the lead?
So I'm actually not sure if DoCare was the lead. I just know that DoCare was there. I know Honolulu police were there, and I know that there were citations issued, and my understanding is that they're following up, whether they're doing it in coordination with each other, because jurisdiction isn't really the issue. Everybody has jurisdiction there. The county police have jurisdiction, DoCare has jurisdiction, but
I mean, jurisdiction is always the issue. If they wanted to do a giant party at Iolani Palace, the Iolani Palace gatherings are always an issue of jurisdiction.
Oh, I agree.
Because you got if they wanted to do a giant, some that authority block party at Mauna Kea, jurisdiction would be an issue. So I guess I'm not trying to trap you on this. I'm just looking for, is this something that's going to be addressed in this press conference this afternoon, that we're not going to have to worry about jurisdiction this weekend? If people see a party, they call 911, and they can be assured that as many people that are identified there as possible are going to get punished for flaunting the law?
Yep, that is my understanding, and that's what's good about what happened with that other event, is DoCare was on site, Honolulu PD was on site, and they were cooperating and coordinating. So jurisdiction didn't become a problem like you have suggested it has been in other situations. And that is going to be our goal. That is our effort, to have just the illegal conduct we see addressed and jurisdiction not become an issue, that it's coordinated.
Well, so if you could help us follow up on whoever the lead in the investigation of that Alan Davis incident was, I would like to ask them what the total number of citations were and whether in their investigation they were able to identify and cite the organizers and what penalties they were seeking on those individuals, because as we just talked about with the court case situation, I think it would be very helpful for the public to understand that the promoters and then the attendees actually were punished for flaunting the law like that. I think that would be great information to have, like maybe on the nightly news tonight before this 3-day weekend.
I will reach out to Chair Case after this meeting.
I appreciate that very much. Thank you.
Okay, thank you, Attorney General.
Okay, thank you very much.
Okay, so next we'll hear from the Healthcare Association of Hawaii and Department of Health. Good morning.
Good morning, Senators.
So on the agenda, we actually had the specific questions to help you guys prepare for providing information for the hearing. So hopefully you were able to review that.
Yeah, so rather than addressing each point, it may be easier to just kind of hit it overall. We've been working very closely with Healthcare Association, with HIEMA, with our federal partners from FEMA, HHS, and also the Department of Defense. And Hilton's been right up in there. He's probably been more active with this than I have. The bottom line up front is we figured out something. We have a little bit of a reprieve, at least for the next couple of weeks, with regards to the amount of oxygen that we will have in our state. It's a question of how much oxygen we are producing or bringing in versus how much oxygen is being used. And so because both sides of those equations are changing right now, it's making it really challenging. And then additionally, because we're an island state, you know, when we talk to the guys in Florida, when they're running short, they trucked it in from a neighboring state, and that's not an option for us. And the timeliness of bringing it by sea lift versus, you know, some other mechanism, i.e. Flying it in, also create challenges, and nobody wants to fly the oxygen, and there are safety issues tied to that. So, Hilton, I don't know if you want to go over the numbers or if you want me to do it. We've kind of been working on it together.
Is he on?
Yes, good morning, Senators. Thank you for the opportunity to present. I do have some slides that I did prepare.
Okay.
If
Yeah,
I'm not sure if some.
Yeah, why don't you go ahead and present that?
Okay. Do you want me to present them, or do you want to? Is there someone there? I can pull them up if that's okay.
Yeah, that's fine.
Okay, so let me just get this organized here. And thank you for the opportunity to present. Do you see my slides?
Not yet.
Hang on. All right.
Oh, there they go.
Okay. All right. Thank you for the opportunity to present. And we do. There is a lot of people that have been working together, and we do appreciate very much the collaboration, cooperation with the Department of Health, AIMA, other agencies, and individuals. So let me. All right. I just want to provide a little bit of context, if I may. Let me start with the good news, some good news. So we track every week how Hawaii does in terms of infections. And these numbers are updated nationally every week. And for the duration of the pandemic, these measurements were started in March 7th of last year, and they're done every week. So this chart is now almost a week old, but we'll get new numbers on Monday. But as of the end of last week, Hawaii, for the duration of the pandemic, has the lowest infection rate in the nation as a state. So that's something we can be very proud of. In terms of deaths, this is the other statistic that is tracked every week. And as you can see here on this chart, Hawaii, for the entire duration of the pandemic, has had the lowest death rate in the nation. So we can be very, very proud of the fact that as a state, we have the lowest infection rate and the lowest death rate in the nation up until now. So that is some good news. In terms of infections, just to provide some context for some of the remarks I'm going to make, this chart here tracks, and this is updated every week also, this tracks the infection rate per 100,000 individuals in Hawaii. And if you look at on the left-hand side of this slide, you can see a number there, which is 124.2, which was the week of August 23 through 29 of last year. Now that was a prior peak in terms of infection. So at the peak of the pandemic last year, we had 124.2 infections per 100,000 people in the state of Hawaii. And then you can see on the right-hand side of this chart what has happened since then, and we've blown past that, even though we have right now about 63% of our population fully vaccinated. we now have an infection rate per 100,000 that is 3 times the infection rate that we had at the peak of the pandemic last year. Now, given that over 90% of the infections in the state are unvaccinated individuals, that means that we have an active infection rate in the state right now of 6 to 7 times more than what we did. This is in the unvaccinated population. We're having an infection rate of 6 to 7 times more than what we did at the peak of the pandemic last year. So that is rather a sobering statistic. This particular chart here shows the COVID patients per in-house per day. And this is a couple of days old, but as you can see there, on the left-hand side of the chart, at the peak, we had 291 COVID patients in our hospitals in August of last year. And then you can see we've surpassed that, and for the last week, we've had over 400 patients today in our hospitals. And today we hit a new record of 446 COVID patients in our hospitals statewide. This particular chart shows ICU patients, and this is COVID ICU patients. And as you can see here, at the peak last year, we had 64 COVID ICU patients in our hospitals. Now we have, as of today, over 100 COVID ICU patients in our hospitals. And the last chart I'm going to show is this one, which shows the number of admissions per day. And as you can see on the right-hand side of this chart, we're now looking at 40, 50, 60 COVID admissions per day. So just to provide some context. So in terms of, I just want to provide some comments about the staffing. We were very, very fortunate to get FEMA support for hospital staffing. This was collaboration with Department of Health, Hawai'i, and FEMA. We had 46 personnel started on the island of Hawaii on this August 16. 201 started on August 23, another 191 started on August 30, and we have approximately 200 scheduled to start on Monday of next week. And then with a final deployment on September 13, so there'll be a few more coming the following weekend. Now that's a total of approximately 650 registered nurses, respiratory therapists, and other technicians, but primarily ICU and med-surg nurses. Each of these waves will be on the island for 8 weeks. What this tells us is that without these 650 individuals, we would be in a very fragile situation. We are in a critical situation right now. But if we did not have these 600, or when they all get here, which is most of them will be here this weekend. So by the end of this weekend, we'll have over 600 individuals on islands across in 18 different hospitals across the state. It just demonstrates how fragile our healthcare workforce is, and we are evaluating the need to extend the deployment beyond the 8 weeks. But that's a pretty significant number of people. Just to give you some context, last year when we brought in staff to the state, we brought in about 150 acute care staff last year. And this year we're bringing in 650. So just to give you some context in terms of the numbers. In terms of post-acute care staffing, we also have significant shortages in our post-acute care units. We have capacity in our long-term care facilities. We have the space, we have beds, we have supplies, we have equipment. What we're most short of is staffing for a variety of reasons, including the impact of the pandemic, people quitting, people retiring, people leaving the islands. Now, one of the advantages of post-acute care, or one of the benefits, is it helps us to decompress patients. Today, for example, we have almost 30 patients sitting just at Queen's Punch Bowl who are waiting for placement. And we have capacity in our long-term care facilities. We just don't have enough staff to take these on. Now, the House leadership asked us a couple of weeks ago to put a proposal together for staffing, and what you're seeing on the slide here is that proposal. So we have, and this was, so this is a current proposal. The numbers are a little bit higher than the numbers we provided to the House because the labor costs have gone up just a little bit. But this is a proposal for the state to bring in a total of 242 personnel into our long-term care facilities for an 8-week deployment at a total cost of just over $10 million to help support our long-term care facilities and decompress our hospitals facilities. But we are seeking funding for this proposal at this point in time. In terms of some other good news that we're working on, FEMA is also providing support for subcutaneous monoclonal antibody treatment. Now, this is treatment that is approved to help. This is if someone tests positive for COVID, but does not require hospitalization, and there are some other criteria, they can be treated with monoclonal antibody therapy, and this has proven to reduce the number of hospitalizations. Now, we have a number of hospitals and other sites across the state that are already providing this treatment, but because of the shortage of clinical personnel, because we've got so many deployed in hospitals and long-term care facilities, we can't expand. We don't have additional staff to expand and run even more of these clinics. We're working with FEMA. We've just got approval. We believe we have formal approval, and to bring in 6 teams to support, to run clinics at 6 different sites across the state. The sites you can see there, we're looking at Queens West, one of the Hawaii Pacific Health sites on Oahu, Maui Memorial, Hilo, Kaiser, Oahu, and also Waianae Coast Comprehensive Healthcare Center. So those are the 6 sites that have been identified. We are hoping to have staff on the ground next weekend, so they will arrive at the end of next week, and they can, the hospitals or these sites will provide logistical support, do things like scheduling and things like that. But these staff that are coming in, these are civilians that are funded under this FEMA contract, they will actually be doing the administration, which is the subcutaneous or the injections of this monoclonal antibody treatment. So this is a significant effort because we're going to have 6 teams. They'll be able to work 6 to 7 days a week to treat as many patients as possible and avoid, this will result in avoidance of significant number of hospitalizations. So we are very, very appreciative of this. And again, we expect to have those teams starting to arrive at the end of next week. In terms of oxygen, and Dr. Cha made some summary comments. Let me give you a little more background. This particular issue, which obviously was very, very critical, we first became aware of this when Airgas, who is a major oxygen supplier in the state, they came to us they actually went to the federal government on Friday of last week, just a week from today. They went to the federal government and said, according to their calculations, that Hawaii would run short of oxygen. Now, that Hawaii was not going to run out of oxygen. It just means that we would run short of oxygen effective September 6th. That was their calculation and their message to the federal government. So we mobilized, and when I say we, this is a multi-agency action to respond to this. We had Department of Health, HIEMA, Hospital Association, vendors, Matson, Airgas, Matheson, multiple state agencies involved and federal agencies involved. And it has been an incredible amount of work that was done, especially over the first 4 or 5 days after this became an issue. So where we are right now, as Dr. Cha said, we have mitigated the immediate crisis. So we are fine. We're not going to run short of oxygen on September 6th. Let me just run through really briefly what we're working on. So one of the first things we put in place, we are working with the chief medical officers and chief nursing officers of all of our hospitals on oxygen conservation strategies. So the CMOs, we met with all the CMOs, the chief medical officers on Monday of this week, and again on Wednesday. On the Wednesday call, we reached out to the university, to President Lassner. He connected us with the School of Engineering. We have 5 engineering professors from the UH School of Engineering who are working with our hospitals to help them on these oxygen conservation strategies and provide support. So that is something that is having an immediate effect or impact in terms of the use of oxygen. And this, what this means is that we're still providing oxygen as needed We're just making sure that we don't provide more oxygen than what is needed. And we believe that these oxygen conservation strategies, which are in effect in every hospital right now across the state, including AAA, everyone's involved, will have an immediate impact. Well, obviously, this has raised awareness within the physician community, so we have widespread physician support. Now we are working to identify additional ISOs. The ISOs are the containers, these 20-foot containers that are used to ship oxygen across jurisdictions or across the ocean. And there is a worldwide shortage of ISOs because of the global demand for oxygen. However, what we have been able to do is that Matheson, who is one of the rather smaller of the two oxygen vendors in Hawaii, Matheson has one tank, which is one of these ISOs that is normally used to transport argon, and they are converting that at a manufacturing plant in California right now. It's been converted from argon use to oxygen use, and that will be put into the Pacific rotation. Airgas, who is the other vendor, they and the major producer of oxygen in the state, they have converted two of their nitrogen ISOs to oxygen, and that conversion has already happened. So and those ISOs are already in rotation. We're working with Matson. Matson has been very, very supportive and helpful in terms of helping to increase the turnaround times of the rotation. Both Airgas and Matheson have maxed out their capacity in the state. Normally, Matheson and Airgas would produce medical grade oxygen, commercial grade oxygen, and other gases. They are 100% focused right now on medical grade oxygen. They're no longer producing commercial grade oxygen or other types of gases right now. So 100% of their capacity is reserved for medical grade oxygen. In addition, we are bringing oxygen generators into the state. Kaiser brought in an oxygen generator from California early this week. It has been plumbed into their facility at Moanalua. Hawaii Pacific Health is bringing an oxygen generator in that they'll be plugging into Polimomi. There are 3 federally funded oxygen generators that have been identified that should be here in mid-September. So these oxygen generators won't replace the need for the liquid oxygen from the manufacturers, but it will certainly supplement that demand. In addition, we're also looking to find even more ISOs, and we have a lead on a couple of those right now. Hopefully we'll hear later today. So in summary, while this crisis was identified on Friday of last week and was brought to our attention by our oxygen suppliers, we have averted the immediate crisis through an incredible amount of work and energy by all the parties involved. Right now, we've pushed off that crisis for probably at least 2 weeks, that crisis point, but we believe by all the efforts that we're engaged in right now, which is conservation, identifying additional ISOs, and reducing turnaround times for these ISOs, that we will not run short of oxygen in Hawaii, even based on the projections that we do have for the peak, which is yet in front of us. So that is very good news that it has been averted, but it was and is a major initiative to address this issue. I just want to make some final comments here based on the meeting we had with our CEOs this morning, all of our hospital CEOs. So we have as I just mentioned, we have a record number of COVID positive patients in our hospitals today, 446. So that is a new record. That is an increase of 330% since August 1. So on August 1, we had 134 COVID patients in total. As of today, we have 446. So, and the numbers will continue to climb. We believe they will continue to climb. You heard from HIPAM, they believe the numbers will continue to climb. All the models we have say the numbers, hospitalization numbers will continue to climb. at least into September, if not through most of September. Now, COVID patients, as you know, by definition, they are infectious. They require higher levels of care than a non-COVID patient. And so every COVID patient is not just one patient, it's a COVID patient, it's an infectious patient, and it does consume more resources than a non-COVID patient at the same level of care. Now, we have 223 licensed adult ICU beds in the state. 223, that's the number of licensed adult ICU beds we have in the entire state. That includes AAA. Not every hospital has ICU beds because they don't have the staffing, they don't have the capability, the infrastructure to support ICU. So, but we do have 223. As of today, we have 224 adult patients in our ICUs. So as of today, we have more adult patients in our ICUs. And the reason I say adult is we do have pediatric and NICU, neonatal intensive care, and that's not a critical point at this point in time. Fortunately, this pandemic has spared a lot of our kids, so I'm just focusing on adult ICU patients. So again, as of today, we have 223 licensed adult ICU beds in the entire state. As of today, we have 224 adult ICU patients. Now, what that means is that not every hospital has filled up all of their ICU patients, all of the ICU beds. However, as of today, Hilo Medical Center, Adventist Health Castle, Queen's Punch Bowl, Wahiwa, Holimomi, Straub, and Kuakini are above their licensed ICU bed capacity, and 2 additional hospitals are at capacity. That means that every hospital on Oahu with ICU beds, except for AAA and Kapilani, is at or over their ICU capacity. As of today, before we even get into this long weekend. Now, we do have sufficient total vents in the state for now, although we are having to start to move vents between some facilities, so we do not anticipate running out of vents at this point in time. We do have sufficient oxygen, as we talked about. The FEMA-funded staffing has allowed us to avoid implementing crisis standards of care, at least for the immediate future. If we did not have this FEMA-funded staff in the state right now, and as of today, we have 438, we have 200 more arriving this weekend, it is very possible that some of our hospitals would be operating under crisis standards of care right now if we did not have this FEMA-funded staff in the hospitals. And our own staff are doing the bulk of the work, but the fact we have 438 FEMA-funded staff in the hospitals right now, 200 more coming this weekend, will be incredibly helpful. The most critical, my last point, before I turn it back to you folks, the most critical potential break point or failure point that I see right now is our ICU capacity. So we're getting close to not being able to provide ICU care for all patients needing it, which means some patients will not get the optimal level of care to maintain health and potentially life. Thank you.
Okay, that's hard to hear. So the community could end up losing lives for non-COVID related issues because COVID patients are taking up most of the ICU beds.
They're not taking up most of them, but they are taking up a very significant portion of the ICU beds. Let me just pull up the numbers real quick and I'll tell you exactly how many COVID ICU patients we have today. Let me just find the right file. And okay.
95.
Sorry, do you have it, Dr. Cha?
Yeah, he said it was this morning call was 94 for COVID at ICU.
Yeah, so COVID ICU actually 99. Yeah, so COVID. So we have 224 total patients. Sorry, 224 total adults in our ICU beds. 224, and 99 of those, which is about 45% roughly, are COVID positive. So almost half of the ICU patients, adult ICU patients we have right now, are COVID positive, and about 85% of the COVID patients in our hospitals right now are unvaccinated, about 85%. So 15% are fully vaccinated, and are breakthrough cases who are unfortunately being infected by unvaccinated individuals, but about 85% of our total COVID census is unvaccinated.
Questions, Senator Kim?
Thank you, Hilton. Thank you, Hilton. So you folks obviously anticipated these things happening because you went ahead and planned and prepped to get more staffing, right, for hospitals, and it's coming in by this weekend. You said we'll have most of them here. So you did anticipate this continued rise. At what point did you actually share all of this information with the governor and with the Department of Health?
We are communicating on a daily basis, if not multiple times a day, with Department of Health, HIEMA, we typically do not, we don't communicate every day with the governor, but we, these numbers, for example, we are meeting right now 3 times a week, Monday, Wednesday, and Friday mornings with all of the hospitals, and Department of Health and HIEMA are participating in those calls, and that's when we collect all of this information about the census for any given day. And then every day we do put together a more detailed worksheet, and that is sent to HIEMA and the Department of Health. So that goes out every day, and we've been doing that for many months.
So at what point was it that you folks anticipated you're going to need more personnel? When did that decision get made?
So the numbers started to climb in early August. And we're tracking every single day, and as our projections, based on all the models in early August, we anticipated that we would need more staff, and so we went into a full court press, and we worked with, we started conversations with Department of Health, HIEMA, and FEMA, and fortunately, everyone worked together and were able to initiate this deployment. And so they started again on, as I just said, we got those 46 that started approximately 3 weeks ago on the island of Hawaii. And they started on the first group started on August 16. So we started on the Big Island because Hilo and Kona had the most acute need at that point in time. So we had started, I think it was less than 2 weeks from, so basically the beginning of August, as our modeling showed that our numbers were going to increase, and the modeling, unfortunately, has been uncannily accurate. You heard all the information from HIPAM, but we have a variety of models. We look at HIPAM, there's other models we use, and all of the models were showing that by mid to late September, we would be experiencing a very large number of hospitalizations. And unfortunately, that modeling has proven to be uncannily accurate, but we were able to act at the beginning of August, to start the deployment of these individuals. And again, by the end of next week, we will have about 650. And these are highly trained individuals. These are med-surg nurses, ICU nurses, telemetry nurses, respiratory therapists. They have been an incredible resource for the state, and it is possible that right now, given our current census, that if we did not have these personnel in the state, some of our hospitals, one or more of our hospitals, could be operating under crisis standards of care right now if we did not have these staff to supplement the staff we have at our facilities.
Thank you.
Senator,
with that,
I'm sorry.
Go ahead, Dr.
Senator, so we had this contract in place because we did exactly the same thing last year, and we actually did, with the same company, bring in a bunch of additional healthcare workers last year, right? It was right about August, I think, and thankfully, we got everything in place. We brought the healthcare workers out, and we didn't need to use them. It was a different ballgame. We didn't have Delta variant, but we did the same thing last year.
Okay, but based on all of the modeling, based on these projections, the fact that our healthcare knew or anticipated we're going to have all of this increase, why didn't we do more to prevent, to be at this point now before Labor Day weekend? I mean, we've known a month ago that we're anticipating this. Why haven't the state done more so that we wouldn't be at the point where we have more patients than we have ICU beds? Because we kept hearing, okay, as soon as our hospital beds get to the point of criticalness, we're going to have to put things into place. But why haven't we done it?
Senator, the Department of Health has been working very closely with the Healthcare Association, and we have been advocating for that for quite some time now. We've been watching it. We've been, saying that from a public health standpoint, we absolutely supported further restrictions, trying to work with the policymakers towards that end. But the Healthcare Association and the Department of Health have, I think, been pretty closely aligned.
Okay, so when you say working with the policymakers, basically you're saying the mayors and the governor? Because we have no control. We as policymakers at this point have no control over these decisions, right?
Yes, Senator, you're correct.
Okay, so, but obviously there've been resistance on that level to implement more restrictions, and you folks have been recommending higher types of restrictions.
From the public health standpoint, we have been pretty clear about that.
Okay. Can we expect to have more restrictions today at the press conference?
I don't know.
You don't know, so they're not keeping you in the loop. Okay, thank you.
Senator Ke'oho Kalole.
Can either one of us explain why we need the federal support that is coming or that was asked for the antibody treatment?
I can explain that.
Okay, go ahead, Dr.
So with regards to the monoclonal antibody, what that is it's a treatment that if you are recently infected and we give you this treatment, it kind of ramps up your immune system. And so it should help prevent you from getting really, really sick from it and having to go in the hospital. So that's kind of how it works. And then it's been taken a step further so that in certain cases, if you're immune compromised, even if you haven't yet tested positive, if you had a credible exposure to somebody with COVID, we can now give you this monoclonal antibody. It's been approved and authorized by the FDA, and it will hopefully prevent you from getting sick.
Authorization, by the way, it's been authorized under an emergency use authorization.
Correct.
It's intravenous, so it's a shot.
So it had been intravenous on the first iteration, and what the big breakthrough for us now is that it can be given subcutaneously. So that's even better yet. That makes it more accessible for people because you don't need to start an IV. And so what we did is
that a shot?
It's a shot, but it's under the skin. It's not an IV. So it's almost like you can think of it like how you got your vaccine. It's a little different than that, but you can kind of think of it like that.
I think I understand what the treatment is and why it's used, but I'm getting a lot of questions as to why we are not using monoclonal antibody treatment at a much more massive scale because Donald Trump and Joe Rogan got it and it worked on them.
So we are absolutely using it. And
so
the reason
why aren't we just using it on everybody that comes in the hospital?
So it's a question of, you have to select patients you give. It's like an antibiotic. You don't want to just walk through the room and give everybody the same antibiotic. You need to look at everybody's situation and what their, where in the disease process they are, what kind of symptomatology they have. So you need to tailor it to patient use. It's been available, we've been using it, and we're trying to ramp up the use. Because of the whole staffing shortages and whatnot, it's usually been done through the FQHCs or through the hospitals because you absolutely need medical oversight for this. And so what we're doing is we're bringing in a team of 30 FEMA professionals to come in and help us to augment what we're already doing. And so it's already being used, but 30 additional people will allow 6 more sites to be stood up across the state to augment what's being used and hopefully reach a far wider audience.
So what's to prevent the 190,000 unvaccinated individuals on Oahu from swamping all of those stations and going, I don't want the shot, I don't want the vaccine, this is a shot too, I don't want the vaccine, I want the monoclonal antibodies because Joe Rogan got it and it's better now.
Okay, so it's completely
pivoting off of Senator Kim's question. How
So
can we
it's-
get prepared for that?
it's inappropriate to do that, and it's a very temporary thing. It will temporarily boost your immune system just for that single exposure that you had. It's not a panacea. It doesn't protect you for the next month or anything like that. It's a very, very temporary thing, and it's got to be done under a doctor's order, and it has to be done under strict medical care. And you get a dose of this. You need to sit at that site. You get monitored for at least an hour to make sure you don't have side effects from that, and that you don't have any untoward reaction. It's a very tailored treatment. It's not something like just going through a crowd and passing it out. It's very, very tailored for specific situations. And it's for those who are specifically immune compromised when it's used in a prophylactic way. Other than that, the vast majority of it is to be used for those who have.
They don't want a vaccine. I mean, I don't want to belabor the point, but the reason I bring this up is once this hits the news, we are all going to be overrun by the same folks who asked me the other day why we're not using ivermectin and monoclonal antibodies. And the fact that we need federal support to come in and ramp up scale on it, the assumption people are going to be making, I can already anticipate the emails, is that the healthcare community did not adequately stock up on monoclonal antibody treatment. And so now they need help because they hadn't, I can already foresee the same assumption being made as the one we are asking you about with the oxygen. And it's very difficult for people, unless we do some broad outreach on this, for people to understand why in Hawaii, you need to have very specific and high-risk medical factors in order to get it, when rich and famous people can just get it as soon as they test positive.
Yeah, so again, there are 2 different uses for it, and it would be inappropriate to it is a medical treatment.
Yeah, so it's, if I can just add, it's, again, as you, Senator, as you just said, you have to be positive, you have to meet the criteria, you cannot be hospitalized. This is not approved for, once you're hospitalized, it's too late. So this is between when you get positive, the 7 to 10 day window between you get positive and when you could potentially show up in a hospital. So it's within that window, you have to be positive, you have to meet the criteria. And the injection, which has only become the subcutaneous method of administration, which has only become available more recently, it's actually 4 shots. So you actually have to get, within the same period of time, you get the 4 shots, then you have to have the RF monitoring, as Dr. Cha talked about. So it is and we have been doing it. We've been providing it at a number of sites. Excuse me. The problem is we don't have enough personnel to run more sites because we've got so many people doing vaccinations, doing testing, doing screenings, taking care of our patients. We've literally run out of clinical people in the state, which is why why FEMA has helped us bring in more people to run these clinics. So, and it's expanding what we're doing. We have, I don't know the exact number of monoclonal antibody sites we have across the state, but it is being done in a number of different sites across the state, and this is expanding what we can do simply because we don't have any more personnel to expand it ourselves. So we're having to bring in federally funded civilian personnel to expand the capacity even further.
So last question, and I'll get off of this. You said it's 4 shots for antibody treatment. Are there side effects to the 4 shots of Regeneron monoclonal antibody treatment?
I think it's more a matter of watching for adverse reactions, making sure that people don't become hypotensive or tachycardic or have allergic reaction symptoms and whatnot.
Senator Favela.
So again, for my concern is that educating the public and letting the communities know. Right now, I've been getting a lot of calls from the neighbor islands, resources, everything is on a big shortage. Right now, they don't have enough testing, enough vaccination sites in Kona, where is being big demand for having these vaccines and this testing. But the way they have them is a 2-hour period, people working, or they're not be able to get access to them. So again, on the neighbor islands, few meetings that we had, talking to the healthcare industry, everything is concentrating on Oahu, which is great, you know what I mean? Because, okay, it's fine, I live on Oahu. What about the people that's on the neighbor islands who's suffering right now, especially in Hilo? Hilo has access to a certain healthcare. Kona is shut down. So, you know, you're talking about FEMA and all of this. So if the military wants to help out as much as they're saying they're going to help out, then they should make the kind of like how they do with NASH. Start opening up, then using their Army personnel or Navy or any doctors that they have available to really come into the communities in Hawaii and really try to curb this thing, getting this thing more of a handle on it. Because we can add everybody to these clinics. Okay, so I'm gonna give 1 to Kona, I'm gonna give 1 to Hilo, I'm gonna give 20 over here in Punch Bowl. What is the dynamics of the community needs? Because right now the neighbor islands are screaming that Oahu is getting everything, and the neighbor islands are getting nothing.
No.
So that's just wanted to know, how can you educate the neighbor islands on trying to get as much as they're doing for them as we're doing here?
Well, can you address first, what's the shortage situation in each county? And then secondly, how do you plan to address the shortages of testing and vaccinations in each county?
So with regards to vaccination and to Senator Favella's point, we speak with the district health officers every day. And I know for the monoclonal antibodies, that was a decision that was made involving all the counties and all the hospitals. And it's really a matter of, again, it's available in every county. And so this was to augment those needs. And so it's, you know, where do we have the greatest need to be administering additional doses? And that's how they arrived at that. Every county was involved and there were discussions with all the various hospitals. As for vaccine, we have a lot of vaccine in state still yet. We have over 300 sites statewide that we're administering vaccine, and we are trying to pair, to the extent that we can, the testing with the vaccine. You know, we're having some challenges, I think, just to reframe that this is a worldwide pandemic and it's flaring across the nation all at once. Whereas last year it was kind of popping up really badly in Texas, and then it was really bad in Florida, and then that kind of settled down and it was popping up here and there. Right now, it's like the entire nation is flaring at once. And so we're almost competing against the rest of the nation for resources. That being said, we're okay with vaccine right now. We're trying to increase the testing capacity and some of the resources. The other challenge that we have is, you know, it's been a year and a half, and all the partners that we've reached out to and the other agencies that can help, including the private sector, I think everybody who's willing to assist with vaccination and testing and whatnot, we've got the vast majority of them on board already. And what we had done was people who were helping with testing, when we started doing vaccination, we kind of pivoted a bunch of them to help with the vaccination. And so now we're going back to testing, but we don't want to pull them all off of vaccination because we want them to continue doing that as well as doing testing. So it's a little bit challenging just because we're doing sort of all these things all at once. Whereas in the past year, it was sort of a sequential effort, so we could shift people around. Trying to do all of them at once right now, so we are having a little bit more challenges.
So is there a wait?
Just the need.
Is there a wait for tests? Because some of the neighbor island constituents are saying that they're waiting as long as a week to get access to tests. So I would think that the numbers that we get daily may not be accurate, just because we don't have access to tests.
So we do have testing statewide, and we're in the process of enhancing that and bolstering it. We have contracts in place. Actually, the neighbor islands are covered, and we're we're trying to finalize the Oahu piece of it. So we do have pharmacies involved. National Kidney Foundation is doing it in conjunction with Roberts Hawai'i, and I think it's Cure Diagnostics, and some of the other local labs. So we're trying to blanket the state with 30, I think it's like 37 different sites. City and county's been helping a lot on Oahu right now. We're testing in schools, we're testing in prisons, really, really high amounts. We are testing in the vulnerable populations that we're identifying off of the zip code maps. We are trying to set up other programs as well. We're trying to work on a voucher program, and we're trying to adopt several of the national initiatives for Operation Expanded Testing and some of the other things that are available to us. But I think there's just so much need right now. We have 11,200 active cases of COVID right now. So we're trying our best, but it really is just an unprecedented amount of COVID in the community. Delta has been a complete game changer.
Yeah, I think that goes back to what several of us have been asking. If it's as bad as we've just been discussing, yet we don't have a tier system and we don't have restrictions attached to to the different tiers. So that's where I think we're finding it a little difficult to reconcile.
Well, several of us had helped the county, at least on Oahu, to draft the tier system. I had worked on that before I started working in this job, but we'd be more than happy to help the counties if they wanted to draft another round of tiers.
Okay.
We're actually having meetings right now, and I'm not there, obviously, I'm here, but I think they're actually having discussions right now, so I don't know what the fallout will be from that.
But at what point do you, as Director of Health, say, okay, we've allowed the county some flexibility to come up with tier systems. We're at this critical stage. I'm the Director of Health. This is what we're going to start to impose. What point do you do that?
I have voiced what my recommendations are from the public health standpoint, and I think some of it has been adopted. They have added the vaccine policy. They're adding in the enforcement and whatnot.
But have you used all your statutory authorities fully? I think the Director of Health actually has some additional statutory powers to deal with certain health situations.
I'm not sure what you're referring to. I'd have to get together with Attorney General and get some guidance on that.
So, Doctor, you just brought up one factor, and you hit it right on the head for the neighbor islands. The reason why I'm bringing this up, because you brought up Roberts Hawai'i, and they're helping you guys. Yeah, they have over 50-something drivers out. They cannot make the minimum requirements in taking the kids to school safely. They cannot even provide the vaccine or even the testing that you guys are having them help you guys as vendors on the neighbor islands. This is the reason why I bring up Kona, because the guys in Hilo or Kona gotta travel hour 45 or 2 hours back and forth on the same van with infectious patients or people. So the amount that we're talking about here is that, as what Senator De La Cruz just said, you as the Department of Health, when are you gonna say, you know what, Hilo Island, sorry, but you guys schools gotta close because we have no personnel to help take your school kids to school safely on there. We gotta use the resources to start doing testing and vaccination. When are you gonna determine island by island? Because the neighbor islands are hurting. Okay, all the resources, we're taking up all the resources. I'm not saying we do what we are, but the neighbor islands are hurting. When are you gonna take the leadership role to the Attorney General and tell the governor and the mayors, look, I am the health person. This is what I'm gonna put in for Kauai. This is what I'm gonna put in for Maui. This is what I'm gonna put in for Hilo. When are you gonna take that role before we reach the person that you guys are saying? All these other things are great. We're getting from FEMA and getting all this help here and there. But as the person who have the knowledge in health. The governor don't know. Our mayors don't know. You guys are the professional. We are looking to you guys. When are you going to say, you know what, Hilo, we got to shut your schools down because we don't have enough bus drivers, we don't have enough resources out there, we're contaminating the drivers, going back and forth. Now that we get this mandatory vaccine, the mandatory 10-day quarantine, we don't have personnel. To be safe for your island, we will shut down your schools, shut down certain things so that we can reorganize our care system. Because right now, that's where they're hurting. Kona is hurting because the guys coming from Hilo can get tested, but they don't get back to work till after 10 days. So their resources are over strapped already. And they're trying to help you guys in doing testing and monitoring because you guys hired them as a contractor, but they're suffering out there in the neighbor islands. And that's what I'm saying. Exactly what Senator De La Cruz said is 100% on the head. When are you, we're not going for the counties, we're not going for the governor, when are you going to decide to say, you know what, we got to get it on. We need a tier system. This is what I'm going to implement it island by island. Because this is the only way, I tell you right now, this is the only way I can see the curve. Because the Senator De La Cruz and us here, we're getting pounded by the neighbor islands thinking that we here on Oahu, that we don't care about the neighbor islands, and we do. Because we love each and every one of them. But that's how it's seeming in the media. There's nothing for the neighbor islands. So we need one person to come on, huddle up as the quarterback and say, this is what we're going to do for our state, because this is what's right. And regardless of what the backlash, like how they did to Kurt Caldwell when he did his tier system, but it would work. It had worked. And we had the numbers. Look at the numbers you guys are showing us. You just showing us the numbers. Look at it. We're far more now. We get vaccine. Back then, we never had one vaccine. It was way lower. Why? Because we had a system that was working. So when are we going to go? When are we going to go back to something that we can tell and the families can see something that's going to work? That's all we're asking here. That we really need somebody to take that role. So huddle up with the Attorney General, find out what is your powers as the head health person to implement it, tell the governor and the mayors, this is what we will do as the health department, and you got to stand by that word. That's all. That's all we're asking. Thank you.
Senator Kidani.
Thank you. Dr. Char, do we have a dedicated media team to help get word out, whether it's Facebook or however, Instagram, however our younger generation gets their news, to let them know how bad the situation is, that our hospitals are filling up? I read it in the paper, I see it on the 6 o'clock or 10 o'clock news. I don't know that it's getting out to the people that are actually out there spreading it. So I was just curious as to whether or not we do have a team dedicated to do this.
We do have people dedicated to it. It's a small team, and we're in the process of augmenting. I think somebody else is supposed to be joining the team. Maybe it's today's the 3rd. So within the next few days, we're augmenting that team. And I agree with you. We need to get the word out to, a lot of the younger population where we're seeing it. So we need to do a better job messaging with them. And a huge part of this is messaging and getting the word out to people. So
Thank
yes,
you.
we could use a lot more, and we're in the process of doing that.
Thank you. My next question is, do we have any kind of data as to breaking out by age group or by type of profession, numbers of people who are unvaccinated or who have been tested positive or have been linked back to spreading the COVID? Do we have any of that data?
So we do have breakdowns in various categories. On the DOH website, you can see the age groups with regards to vaccination. And also we have zip code maps. You can see a geographic distribution, but we don't have it by profession or some of those other categories, but we do have it by age. We have it by zip code mapping and We have it by, trying to think what the other ones are. We have
So,
one by
so
race
by,
as
by
well.
that data that you have broken out, does anything stand out, like age group or zip code or?
Yeah, definitely. So we know that we have vaccinated over 90% of our kupuna. And I think, we lead the nation in that. And I think that's one of the things that's really been helping us to keep down the fatalities and the severe illness and hospitalizations. That was really key for us, that we managed to get that many, that percent of the kupuna vaccinated. And so what we're seeing now is a shift, just like the whole rest of the nation. We're seeing that shift towards the younger population, so the 40 and under. And we're seeing more hospitalizations, or we're seeing more death in 40-year-olds. We've had a few 30-year-olds that have died. And that's where, I think it was a real good community effort early on to vaccinate the kupuna, and everybody pitched in. And that's something that we could definitely use help with now with the vaccination in the harder to reach populations. That's where we need to rely on, for example, in the legislators, where you guys have the awareness of your communities and you have reach out to them. That would be really, really helpful. I think we've had some conversations with some of the senators to help us in that regard. Get people out to those vaccination sites and have events where we can talk to the community and explain to them if they have reluctance. What's your reluctance? Is it something that we can help you address, so that you can make a good decision and make it available? We could really use that help in terms of just being a force multiplier and getting out to the people and having conversations with the people.
Yeah, because I do think that early push to vaccinate our kupuna gave the younger generation, not a pass, but to say they weren't as susceptible. And now we know it's not the case. We're seeing the 30 and 40-year-olds, the fatalities that are coming. So I think the messaging has to get out there, and it has to be their peers, like, I don't know, people like Carissa Moore, Marcus Murray, those people. And I just don't see enough of that in, on the media. And I really think that we need to move on it quickly. Thank you.
Yeah, I agree. Thank you. We're trying to engage some of the people that we think would be influencers for those communities.
So Dr. Char, if you want to just check real quick, you're under the general powers and duties of the department. It's 321-1. C, the department shall have the authority in matters of quarantine and other health matters, and may declare and enforce quarantine when none exists, and modify or release quarantine when it is established. D, when it is determined that there is imminent danger of a pandemic or serious outbreak of communicable disease, the department may refuse, modify, or limit attendance at any school in the state. E, when in the judgment of the director there is deemed to be a potential health hazard, the department may take precautionary measures to protect the public through the imposition of an embargo, the detention of products related by the department, the removal of products regulated by the department from the market, the declaration of a quarantine, or by sequestering items suspected to be contaminated by toxic infectious substances, provided that the director shall find evidence of health hazard within 7 days. The director shall make public findings. All county health authorities, sheriffs, police officers, and all other officers and employees of the state and every county thereof shall enforce the rules of the department. All such powers in health matters as have been or may be conferred upon any county shall be concurrent with those of the department. So you might want to just check the statute, because the county, according to F, the counties have to be concurrent with what the rules that you establish. But I'm not sure. You might want to review this with the Attorney General and see what powers you have to take control of the situation.
Okay. And yes, we've been working really, really closely with schools. We have teams from Disease Outbreak and Control Division that have been working dedicated specifically just to do schoolwork, and to help them craft some of their guidance and their plans.
Okay, what are some of the recommendations that you made to the administration, but they haven't been implemented?
So anything that will help to reduce the amount of person-to-person contact. So, for example, and again, this is just from the public health standpoint. And I understand that the broader context of the economy and the well-being of everybody else gets taken into account. But from our standpoint, it's things like the things that we know that are high risk from the cluster reports. So anytime you have people together that are not wearing masks, that are indoors, they're in close proximity, that are there for a long time, where there's singing or loud noises, loud noises, singing or conversations or yelling and things like that, those are all very high risk. So anything that would involve activities like that, we would advocate for disallowing that.
Was that the only one?
That covers an awful lot of stuff. That's the risk in the behavior, right? That's what we're trying to mitigate. So how do you get COVID? It's when you're in proximity to someone, especially if you're indoors, especially if you're not wearing your mask, especially if you're unvaccinated. That is a huge one. If you're singing loudly, if you're there for a long period of time, those are all the things that confer the risk. So if you can do things that don't involve any of those, then those are safer things. So for example, being outdoors, hiking, that's pretty darn safe. Go surfing, that's pretty safe. Get together with a few people who are in your bubble, who are in your household, that should be safe. Safer yet, everybody's vaccinated in your proximity. Those are all good things. And we should have outdoor spaces so people can go outdoors. There's mental health that's tied to this too. So people should be able to go outdoors and get some fresh air and go for a walk or a hike or a run or swim or whatever. But it's the gathering, it's the indoor stuff, it's people not wearing masks, it's people not being vaccinated, it's the loud singing, it's the, we've had a ton of them in worship situations where, churches or whatever. Because that's employing all the wrong things, right? They're clustered, they're singing loudly, they're close together, so it's really to then go through the list and anything that involves those activities where you have those high risk features, those are the things that we're advocating against.
But Dr. Char, what you're describing is exactly what's our schools. And all of our elementary students are under 12 and cannot be vaccinated yet. Most of them have to sit very close, shoulder to shoulder in classrooms and on the school buses. I don't know, how, the talking loud, et cetera. So I have a real concern that there was not an attempt to persuade the previous superintendent that every child must go back to school. So now the current interim is scrambling to do more distance learning. And I think that's something that from the governor down, the schools, the Department of Health should have had a better handle on, because I don't see any widespread cases in the schools yet. We are talking, of course, we were out for the summer, so now that the students are back, and you say you have a good team monitoring the schools, I just hope and pray that this is true and we are going to be able to control the spread by schools. Thank you.
So with regard to the school, Senator, we have absolutely been working closely with them. The kids are most likely to get infected, especially the ones younger than 12, when they're at home from their families, and then they're bringing it to school. We're trying, the things that we have in place are to identify if a child comes to school and is sick, to shut it down right there so that they don't infect a whole bunch of other people. And in school, they're supervised, they have masks, we don't have them sitting in circles anymore, they're all sitting in the same direction. To the extent possible, it's like, can you eat lunch outdoors? Can you do activities outdoors? and they're monitored every day when they show up. And if there's something with a child, we know who they live with. We can contact trace those, as opposed to them being home and not, or just out unsupervised. They're much more likely, I think, to get into trouble. It's not to say that the schools are not risky. There's absolutely risk there, but it's also, we got to weigh the other risks of them not being in school. The schools are a reflection of the community. And so the best thing we can do is to keep the numbers down in the community. And at some point, the communities are if they get to that point, then yes, we may have to shut down schools if it is just so rampant within the community. And as Senator Favela said, the schools are having a real challenge because so much of their faculty or the staff is out because they've been exposed to somebody. And a lot of that too, it's not that they're exposed at school, it's that they're exposed in their social settings and at home. But once they get exposed, they can't go to work. So it is a challenge. I mean, the Department of Health is having great challenges just with the load of work, just like the hospitals are. And we're trying to do our best to call every single person that gets designated that gets a positive result. We're still trying to call every single person. And it's just been a real challenge.
I don't disagree with you, Dr. Char. What I'm disagreeing with is that there wasn't enough conversation when the previous superintendent basically said every student will go back to school and there will be no distance learning. It wasn't until July 15th Board of Education meeting that chair said that, yes, we will have some distance learning. But by that time, some schools had already started. And the regular opening of school was only 2 weeks away, which was not enough time to have the teachers in place. And that's what we're facing now. And it doesn't mean that parents, knowing that they have possible COVID cases, are not sending their kids to school anyway. So I think this, again, part of the spread is going to come because of, I'm not saying uncaring, but maybe uninformed people out there, and they just need to be getting this message. Anyway, thank you.
Agree.
Dr. Char, when we had the first go around, there was a lot of discussion about air filters, air purifiers, cleaning air conditioning. Is that still something for groups indoors that they should be considering, or is that no longer a priority?
No, you're correct. Even with the Delta variant, things like making sure that you have good airflow and circulation, things like the HEPA filters, they're effective at filtering virus out of air. It's really about having good air exchange and good ventilation. And that's why outdoors is so much safer than indoors.
So I'm not sure if that would help the situation with schools in regards to, HEPA filters in every classroom, or air purifiers, cleaning the ducts for the air conditioning regularly. I'm not sure the protocols that are in place that the schools would have to implement.
Yeah, I'm not sure. I know that the DOH team has made recommendations, but I can't tell you what's transpired on the DOE side.
Senator Keoho Kalole.
Yeah, thank you, Director. I have so many questions and people are sending in questions, but the one I've gotten asked the most by constituents and by a lot of folks who oppose all of the mandates is what the medical or epidemiological justification is for classifying risk differently between vaccinated versus post-COVID individuals. Like for me, if you say someone who's gotten COVID and now has developed antibodies and has a certain level of natural immunity, if you're gonna exempt them from safe travels in the way we do vaccinated individuals, or you're gonna exempt them from being vaccinated for purposes of the Oahu mayor's, coming vaccine mandate, that's gonna have a real chilling effect on the rest of the community who's not vaccinated, who are considering it right now. But from a medical standpoint, can you help explain the difference in immunity you get from getting the shot versus getting sick and then coming out of it?
And so I think, it's a good question because, again, the pandemic is unfolding right before us. So we don't have years of experience of this or know how it's going to evolve. And then the Delta variant has really changed things. But we know that if you get infected with COVID, that you develop antibodies to it. The question is, if you develop antibodies, is that equivalent to what you'd get off of a vaccine? And is it protective against other strains or other variants or not? And how long do you have that immunity? Is it better than a vaccine? Is it worse than a vaccine? And those are all things that are being researched right now. And you see differing literature, so I think that tells me that the jury's not quite out on it yet, and they're still trying to figure it out. And one of these things that we're just not going to know until we have more time to see, a year later, for those that had a native infection versus those that had vaccination, or those that had both. So I think, it remains to be seen, but I know it's being studied. I just don't know that we have definitive answers yet. You do get some degree of protection after you've had an infection.
I guess we get a lot of pushback from that. I'm assuming the other members do. I get a lot of pushback on that from constituents who point to the breakthrough cases and go, well, it's not a guarantee if you get the shot, and so there's a certain amount of safety you get from having been sick, just like there's a certain amount of safety you get from getting vaccinated.
Sure.
If there's some sort of data that we could point to,
yeah,
then I don't have to always go, well, Dr. Char said.
So if you look at, you don't want to be saying Dr. Char said. So if you look at those who are fully vaccinated, 0.3% of those who are fully vaccinated in our state got COVID. 0.3% of those fully vaccinated in our state got COVID. So we still know that the vaccine is very effective and that it's safe. If you look at all of the cases in the hospital, 93% of those, or I guess, it's changing, it's like 90% of those in the hospital right now are unvaccinated. And that number is going to change. The more people we have vaccinated, the more the Delta, morphology, the more the Delta breakthrough cases, and as it evolves, we'll see more and more breakthrough cases over time. That's kind of inevitable. But it's almost 90% of the people who are hospitalized are unvaccinated. And those who are vaccinated, we know that it really helps to limit them from becoming severely ill or from dying. So there is a level of protection that's unequivocal from the vaccine.
If I can add to that, Senator, and add to Dr. Char's comments, absolutely agree with that. In general, if someone's vaccinated and they've got a breakthrough case and end up in the hospital, they're in the hospital for maybe 3 to 5 days at a much lower level. Unvaccinated individuals who end up in hospital with COVID are in the hospital for up to 3 weeks or longer, and generally at a much higher level of care. There's a very, very clear distinction between what happens, or the severity of individuals who are vaccinated and end up in hospital versus those who are unvaccinated and end up in hospital.
Or Dr. Char, do you have data on, this is my last question, I'll defer. Do you have data on the second infection individuals? I don't know what the right term is, but people who have gotten COVID, have a certain level of natural immunity as a result of having been infected, and then who got sick again. Is there data on that? Because that to me seems like a more comparable metric to the breakthrough cases than what we're comparing right now.
There is data out there. It's limited because it's not that common, and so I don't know that we have that specifically for Hawaii versus nationwide or worldwide. They got some of that data when they were checking vaccine efficacy on the initial go around. So I don't know a Delta variant if that exists or not.
If there is any, I'd like to see it, please. Thank you.
Sure.
Yeah, I got another question. So, like for the schools that have health aides or health nurses, through this whole pandemic going forward, did we have any kind of training or any kind of educational for them, as they sense they're going to be the ones that is seeing the children and sending them home to their parents, in the sense of recognizing that they supposedly have symptomatic symptoms for having COVID. Did we start reaching out to the schools and try to educate them, or try to help educate them in getting a little bit more information? So if a kid that came in or somebody came in that wanted to ask questions and get more information, since the schools are in the community, shouldn't they have that kind of knowledge? At least somebody from the school answering these questions, instead of, like Jared said, Senator Jared said, instead of saying that Dr. Char said?
Yes, they did. They have training. It's ongoing, and I believe we're trying to hire to help DOE. We're hiring a bunch more in the Kiki nurse program. I totally agree with what you're saying, though.
I have a question for either Dr. Char or Hilton. When we exceed capacity for ICU beds, there was talk about probably a year ago or a year and a half ago, about us standing up a field hospital. Is that part of anyone's discussion, or is that something that you guys are at least anticipating, similar to what Senator Kim is saying, just even though if we don't have to use it, just try to plan and anticipate?
So we have had conversations about, what other resources we have or can use. The main issue is staffing. So that's the biggest challenge. Even if you put up a tent hospital or something, the staffing is always the biggest challenge. And for a tent hospital, ICU is so resource intense that likely you would be moving other people into the field hospital and keeping the ICU level patients in the hospitals. But it's always really a challenge with staffing. That's kind of the rate limiting step.
But would there be a plan to move those who maybe they don't need they should be in the hospital, but they don't need that ICU type of care, so they would maybe go to the field hospital, so that you could free up the capacity at the hospitals?
Yeah, there have been conversations about it. It's always something that we look at as a contingency, but again, it's you're still going to need the staffing to take care of those guys. Yeah.
Okay, it still goes back to what Hilton had talked about earlier.
Yes, if I can just add to that. So we have a proposal which you saw to get additional staffing for our post-acute, because some of the patients, lower level patients in an acute crisis, could be moved from a hospital into a long-term care facility, because they do have, got a lot of the wraparound services you need, dietary, housekeeping, pharmacy, etc. But again, as Dr. Char is reiterating, that is dependent on staffing. We do have some field hospital capacity. We are actually going to stand up one of those field hospitals at Queens West it's actually going out there today. It will be stood up and ready for operation on Tuesday. So we've already deployed a couple of tents at other sites. So we are already starting to deploy our field hospital capacity. Now, the ones that are deployed right now are being used for outpatient care, for triage care, but they can be converted to be used for inpatient, low-level inpatient care as well. So those, so we do have some contingencies, but again, staffing is a an acute limiting factor at this point in time.
Okay. Well, I hope the administration for the counties and the state consider the triggers, especially in light of what you've explained to us in regards to staffing, the amount of beds out there, how difficult it is to even staff vaccination clinics and testing sites. And, I'm glad you have the oxygen under control, but the staffing and the amount of hospitalization beds still seems to be a big challenge for us. So we really appreciate what you've provided us. It's been very enlightening, scary even. And so we hope we can avoid the surge this coming weekend. So I know a lot of us are probably going to be anticipating what the governor and the mayors are going to say in about 45 minutes. So thank you for all your time. What do you want to say?
Just to
Thank you for
reiterate,
the opportunity.
well, just to reiterate though that Dr. Chai, that the Department of Health, you have that power according to our statutes. So hopefully you will look at that and see how you can protect the community. Unfortunately, or maybe the word is fortunately, it doesn't anticipate economic issues. That is obviously with the governor and the mayors, but you are responsible for the health and welfare of our state. And if we had anticipated this earlier, we may not, I don't want to shut down. So we're trying to avoid a shutdown, avoid some of these things, avoid the bed space being utilized. If we had, slowly done some of the preventive measures, we may not be in this situation, but we are. So anyway, please look at that. Thank you.
There's also section 325-32, immunization against infectious diseases, and 325-6, epidemic control. So if you can take a look at those and see at some point if it's necessary for you to use.
Can I?
Oh, go ahead.
My final question, this can be for either Dr. Char or Hilton, is I've had several emails from people who object to being mandated to get vaccinations. And I was just wondering, and I don't know if it's for religious reasons or others, but when they get to the hospital, are you having any who object to being treated for the COVID?
No, that's a very, very interesting question, because remdesivir, for example, which is a treatment under emergency use authorization for hospitalization, and it has proven to be very effective. So we have unvaccinated individuals who end up in our hospitals who ask for an approved treatment by remdesivir to treat the infections for which they were not vaccinated. So it's an interesting fact that happens on a regular basis. I'm not aware of unvaccinated. It may have happened, but I'm just not aware of unvaccinated individuals who end up in the hospital who also turn down remdesivir. Basically, by the time they get sick enough to go to a hospital, they say, give me whatever it takes to get me well. And that is unfortunate. And we have people showing up at hospitals on a regular basis who said, who are sick, and they get admitted to the hospital and they say, well, give me the shot, give me my vaccine. And we have to tell them, well, it's too late for you right now to get vaccinated. You can get vaccinated once you get discharged, assuming you get discharged, and after there's an appropriate period of time. But vaccinating someone who's contracted COVID and is sick enough to be in a hospital will not help them at that point in time.
That sounds like a great commercial.
Yes, we have many stories of people asking the healthcare workers, as they lay sick, I should have got vaccinated. I wish I knew. Can I get vaccinated now? And as Hilton said, the answer is no, you can't get vaccinated right now.
Let me ask this real quick question. So do you prioritize if, say, you have, 10 patients and one of them is vaccinated and the others are not, and you only have, one bed or whatever. Do you prioritize at all?
No, we do not. We do not take into account ignorance, stupidity, misunderstandings. We treat drunk drivers, we treat, people who do stupid things, we treat people who...
No, I understand that, but in a situation where you have limited amount and, who do you turn away? If you had to turn away anybody, not that you would, but...
Well, fortunately, we have not gotten to that point of time, but whether or not they're vaccinated, that does not factor into the calculations. We do have crisis standards of care, which all our hospitals have, but we do not take into account whether or not they're vaccinated. We treat all people the same way, and but if there is a scarcity of resources, we have a hierarchy, but vaccination status is not part of that decision hierarchy.
But I think just to put things in context, I mean, there are a ton of people in the ICU that have nothing to do with COVID. So we're fitting them in and taking care of them as well, and they're, that's part of the resource needs. We have people in with strokes and heart attacks and traumas and all that, and so that's the population in the ICU as well as all these patients that have COVID.
So wouldn't the hierarchy be, if you have one bed and 10 patients, the one that you think you can save?
Yeah, we base it on medical need. And then the crisis standards of care, that it can become very complex very quickly, and that's why they have worked on it ahead of time and have the basis for the treatment laid out pretty well.
Thank you. I don't envy your jobs. Thank you guys for what you do.
Okay.
Thank you.
Thank you.
Senator Kehokalole.
One last thing, and then I'll stop. I do think that it's important, in light of what you just said, to make it clear to folks, and maybe this should be part of the campaign, because like you guys said, it's too late for people to get the vaccine once they're in the hospital about to go on a ventilator. But I think it should be noted for people in the community, because I get these questions every day. Why not ivermectin, which is owned by Merck, big pharma company, still in clinical trials? Why not the Regeneron, big pharma company, 4 shots, emergency use authorization? Hydroxychloroquine, emergency use authorization, owned by a foreign big pharma company. Remdesivir, owned by a $90 billion big pharma company, emergency use authorization. I think it is important for the public to understand that the alternatives to the vaccine, that they are continually asking legislators like us to push you guys to distribute at scale, are the same type of, are going through the same type of experimental FDA processes and trials that the vaccines are, but that you guys are saying they're just not as comparable in terms of their effectiveness to the vaccine. Because a lot of people are putting a lot of time and effort in trying to get folks vaccinated, and this is the kind of stuff that we're getting in response. So I would ask you folks to consider that with the new personnel that are coming on in Palms. And that's all. Thank you.
Yep, that's a good point for the messaging. Thank you.
Okay.
Thank you.
Thank you. No further business. Adjourned.
Thank you, guys.